हॅलो मॅडम.
हॅलो. बोला.
मॅडम यूट्यूब लिंक चेक करा एकदा. ते पण चालू आहे.
अह, एकच मिनिट हाँ। अब पापा को पूछ ले, उन्होंने यूट्यूब लिंक से ज्वाइन किया क्या? यूट्यूब लिंक उनके पर्सनल व्हॉट्सअप पे सेंड किए हो करतो. कारण की आम्ही काय सगळ्यांनी मोबाईलवरनी जॉईन केलंय ना.
हो हो.
हा, तर त्याच्यामुळे.
राधा मॅडम.
बोला.
मॅडम मी एकदा स्क्रीन शेअर करून बघू का एकदा?
हो हो, स्क्रीन शेअर करून बघतो. तुझं राहिलं होतं त्या दिवशी कारण.
हा तेच.
बाबांनी केलं पण त्यांनी कॅन्सल करून टाकलं. पण जॉईन झाले होते ना ते युट्यूबवर नाही. युट्यूबवर ना जॉईन होऊ शकतोय. हा
ओके मॅडम, ओके.
हा, ठीक है। तू बैठ जाना मेरे इस पे 2 मिनट, क्योंकि मुझे तनु को पूछना है कि वो बात। हेलो, रोहित नीचे गया है जस्ट, तो
लॅपटॉप इथं बघिंग आहे.
सर स्क्रीन शेअर होते
लैपटॉप रखी है।
आणि
हो
जर
हो,
स्लाइड
मी
शो
एकदा
बोर्ड
फक्त
मध्ये
प्रयत्न करून बघितला
हो
की
सर,
स्क्रीन
होते
शेअर
होते.
होतं की नाही होतं.
होते सर, होते.
होतंय ना? ओके ओके,
येस
थँक्यू.
सर.
युट्यूब
स्टॉप
वरनं
कर.
जॉईन होत आहे आणि आवाज पण येतोय नीट.
ओके ओके, चालेल रोहित.
तो यू सिट इन अनदर चेयर, ओके। एंड इफ यू आर यूजिंग द सेम डिवाइस तो दोनों एक चेंबर में भी चल जाता। अभी तुम पहले मोबाइल से जुड़ कर लो फ्लायर पे। उसे क्या समझ गए? तो इसलिए ये बोल रहा है। नहीं,
गणेश व्हिडिओ ऑन होतोय ना?
येस मॅडम, होते ना.
हॅलो एव्हरीबडी.
हॅलो हॅलो मॅडम.
हॅलो, नाईस टू सी यू. येस.
येस.
आता मी सगळ्या ग्रुप्स मध्ये परत एकदा टाकते.
हो चालेल चालेल. हाँ वो इको हो रहा.
गुड इवनिंग
एक
मैम.
मिनिट हा, मॅडम. मोबाईल का क्या इसको कनेक्ट हो गया.
गुड इव्हनिंग.
गुड इवनिंग मैम.
गुड इव्हनिंग
व्हेरी
तानाजी.
गुड इव्हनिंग.
एको एको होतोय.
हो इको होतोय तेच.
सेटल डाउन.
2 minutes we will settle down.
हा हा.
2 डिव्हाइस आहेत ना, त्यांचा माईक चालू असल्यामुळे तो प्रॉब्लेम येतो मॅडम.
हो हो, नाही आलं लक्षात आमच्या. जेनेक्स करतो. हा.
मी आणि मोनिका माझ्याच लॅपटॉप वरनं करतो मॅडम.
बरोबर, जसं जमेल तसं.
हा.
आता गेलो पाहिजे.
ब्लूटूथ कनेक्ट हो गया आपका? रोहित, सेक्रेटरी सर, अनम्यूट.
Yes, madam. I'm here.
हाँ, ऑल गुड ना?
All good. No problems.
ओके. तो इफ आशीष का ब्लूटूथ नहीं कनेक्ट होता है, आई विल सेंड हिम टू योर चेंबर.
Okay.
ओके.
Ashish has arrived.
Yes, he has arrived.
Okay.
Meenal is also there.
Yes, Minal is there.
Yes.
Yes,
Uh,
good evening, ma'am. Good evening, sir.
I am able to see Balaji sir also, our president Sams. He
Oh,
has joined
yes,
in.
yes, yes, yes.
Yes.
Balaji sir is there.
Hello.
Hello, sir.
Good evening,
evening,
madam.
sir.
Good
Very
evening.
good evening, sir.
Good evening. How are you?
I am
Fine.
fine. It's a really a great opportunity for a branch like Amravati to present a webinar at state level.
May I congratulate you, madam. You have done it
No,
nicely.
no, no, because it's the opportunity is
Don't
given at
comment
state
that.
level. That's why it's good.
Yes, it's Balaji sir's initiative. Along with Tagadpalli sir, and it's really really great.
Yes, yes.
राधा मॅडम आणि रोहित सर आज एकदम एकदम इतक्या पिटपॅट आहेत बस.
नहीं नहीं पिटपैट असं नाहीये. Because
प्रयत्न
we have
आहे.
to learn from everyone na. That's why we have chosen those topics who are always controversial.
मी जरा सगळ्या ग्रुप्स मध्ये परत एकदा टाकते. हा हा.
हो हो टाका ना मॅडम. Samruddhi has also joined in.
अ, 55 ला एकदा चॅम्प सरांना आणि आपल्या ह्यांना तुम्ही 2 ह्याच्यावरनं जॉईन झालात ना?
हो मोबाईल वर नाही झालीये आणि लॅपटॉप वर नाही केलाय मी जॉईन.
भरपूर जागा आहे मला वाटतं. अजून सध्या 15 जॉईन झालेत.
ओके ओके.
हम्म.
वेळ आहे अजून ना. स्टील टाइम. 20 minutes. 7 o'clock म्हटलंय ना आपण मॅडम.
12 मिनिटं आहेत. 12.
12 मिनिटं. ओके ओके.
बाकी बालाजी सर आपल्याला अवेलेबल आहेत. सरांना काही विचारायचं आहे का तुम्हाला तुमच्या ब्रांचचं?
Madam, how are your monthly activity going on?
Ma'am, sir, monthly we are conducting academics also as well as
Okay.
CPR workshops also. I have put the updates on our CPR group as well
Yes.
regarding workshops, whatever we have conducted till now. I think
Okay.
only the thing is that reporting is yet to be done from our side. But even at periphery like Paratwada, we have conducted injection technique workshops along with CPR. And
Okay.
till now, we have conducted 3 CMEs. So our installation was along with CME only. Dr. Cham sir had come for as an installing officer that time in June, in the month of June.
Yes.
After following
Okay.
that, in August, yes, in August we had our monsoon CME, which was a obstetric anesthesia CME. We had invited a faculty from Yavatmal for the same, and those were interesting topics, and a good attendance was present for that CME also. It was really highly appreciated by all the delegates who ever attended. Then from our branch at UVACon, I think UVACon was also in the month of August, if I'm not mistaken, at Nagpur. So there were almost 4 young anesthesiologists who presented at UVACon, and our Paliwal sir, he's had been the faculty there. Even Chaudhary sir was there. So it was a very good response academically also. And at ISACON also, there were presentations from our young anesthesiologist, even Meenal, who is going to present today. She also had a paper presentation, a poster presentation at ISACON Pune. And regarding the World Anesthesia Day, we celebrated it as a family get together. So we had dances, songs, and even small skits presented by our members. So even a small kid of our member, a 1-year-old kid, he participated in all those events. It was a really nice, appreciable event, and we got to intermingle with each and every member of our society.
Very good.
Then I'm proud to state also that at ISACON, even if we had just come into the handover was given to us just 5 months back, that is in June. But within that small period of time, like 4 to 5 months, we could make almost 14 new members. We added 14 new members to our society. So we got appreciated also at ISACON for that. We received a membership drive award as well as a public awareness award. So
Yes.
activities are definitely going on at all fronts, academic as well as social front also.
Yes. Very soon we are going to launch our new website on
Okay.
which you will be able to upload all your activities. Then we are
Okay,
coming
okay.
up with one Google form for a CPR program where
Okay.
participant has to just fill the form and he will immediately get the certificate from state. And
Okay.
it will
That is
be,
very
number
good.
will be calculated automatically on our website. So we
Okay,
are also
okay.
trying to do some innovative things on state. Next week we
Okay.
have on 30th recent advances series from Maharashtra State Chapter.
Okay.
And first lecture is by Dr. Jiggy Diwatiya sir about recent advances in airway management. And one new drug or new method is also going to be presented in that.
Okay.
So please attend all those meetings also from state.
Definitely, sir. Definitely, definitely.
I again congratulate you, madam, and all your office here.
Thank you. Thank you very much. Actually, at a branch like Amravati, a lot many activities definitely are taking place. And we have guidance of our senior members also from our branch, like Chaudhary sir, Paliwal sir, Khetan sir. They have been very keen and interested in really motivating the young members to present ourselves at all levels. That's what.
Very good.
Thank you.
अपन टेस्ट कर लेते हैं
टेस्ट करते क्या
People want to check their presentation, they can check speakers.
अभी इको आ रहा नहीं नहीं मेरा आवाज आपको सुना रहा है मैडम इसलिए आपको इको लग रहा है
इसमें भी सुनाई
हाँ तो यार आप मेरा सुन रहे हैं और उसमें भी सुन रहे हैं इसलिए आपको डबल टाइम्स लगता है अदरवाइज इको है क्या इनको पूछो ना रोहित सर इको लग रहा है क्या आपको
नहीं नहीं इको नहीं है अगर मैडम
क्लियर है ना
म्यूट है हाँ मैडम म्यूट है तो इको नहीं है
तर माझ्या याच्यातनं काढून देते.
आणि फक्त एका वेळी ऑन करू नका
Voice is stable, Ashish. No probs.
Sir, mine voice is clear.
Yes, Radha madam, you are clear.
Yes. Okay, sir. Thank you.
Radha madam. राधा मॅडम एकदा फॅकल्टीनं फोन करता का? श्याम सरांना आणि दिवान सरांना. रोहित सर, यू वॉन्ट टू कॉल देम?
I'm calling Cham sir and Divan sir.
Yeah.
गुड इव्हनिंग.
गुड इव्हनिंग श्याम सर.
Good evening, Cham sir.
गुड इव्हनिंग सर. प्रेसिडेंट
Good
सर.
evening, sir.
I saw Dr.
Good evening.
Avinash Bhosle has also joined, I think.
Yes, good evening, everybody.
Good
Good
evening.
evening, Avinash.
Good evening.
Very good evening, sir. Very good
Good
evening.
evening. Good evening.
Tendulkar sir is there. Paliwal sir is there. A very good evening to all of you.
Good evening to everyone. Namaskar, madam.
Yes. Namaskar, namaskar, sir.
All the best.
Thank you, sir. Thank you.
राधा मॅडम दिवाण सरांशी झालं का कॉन्टॅक्ट?
मॅडम कॉल केला आहे. परत कर. मी करते. मॅडम बिझी येतोय फोन त्यांचा.
We will start, but 7 p.m.
I think we should
चालू
start.
करू.
ऐसे शिफ्ट कर देंगे. वेलकम पाटील मॅडम. Thank you, Manisha ma'am. Manisha madam is the president of ISA Thane.
Thank you, Radha. All the very best. It's a pleasure to see Radha grow so much. She was a resident with us in Sion.
Just now spoke to Divan sir also. He's still in the traffic. He said you may start. I will join as soon as possible.
बालाजी सर आणि श्याम सर आहेत. चालू करताय का मग?
राधा मॅडम
Yes,
Yes, ma'am.
definitely.
चालू करायचं मॅडम.
Yes. Oh,
Yes,
because
yes.
he said I'm in traffic. I will take a little bit of time. You may start. I asked him.
Due permission of Balaji sir, I'll start.
Yes, sir, please.
Yes. Myself, Dr. Rohit Kaneriwal, Secretary ISA Amravati. I'm along with Dr. Ashish Bhattad, who is there as a moderator today. Good evening, everybody.
Good evening.
Welcome to the delegates. Dr. Balaji sir, Dr. Rajesh Tagadpalli sir, Dr. Avinash Bhosle sir, Dr. Anita Nete madam, Vikas Karne sir, Parna Thakkar madam, Dr. Cham sir, Divan sir is yet to arrive, but welcome. And last but not least, Dr. Shilpati Vaskar madam. Good evening, everybody. Good evening to the webinar.
Good evening.
I'd like to call on Dr. Balaji sir to say a few words. Balaji sir.
I wish, first of all, I congratulate your branch for arranging such a wonderful topics and speakers also. And I look forward towards your branch. You will arrange many activities in the future, and it will be one of the active branch of Maharashtra state. I wish you best of luck. Thank you.
Thank you, sir.
Rohit sir,
I think we have lost connection. We have lost the connection with Balaji, sir.
No, you may continue, Rohit.
Okay. I'd like to call on Dr. Rajesh Tagadpalli, sir, to say a few words.
Actually, Rajesh sir had called. He will join late. He told me already that.
Okay. I'd like to invite Dr. Avinash Bhosle, sir, to say a few words. Avinash, sir.
Hello, everybody. I congratulate and congratulate to the ISA Amravati team for arranging this webinar. And I wish all the best for their future endeavor. Thank you. Thank you very much.
Thank you, sir. Rohit,
Rohit sir, please continue.
Rohit sir.
रोहित सरांचं कनेक्शन
I think there is some issue with Rohit sir's connection.
Rohit sir, unmute करा. Unmute करा.
Radha madam, is he with you in another room or?
He is downstairs actually. I will call him.
Okay. Is it fine right now?
Yes,
coming
right
on?
now fine.
Okay.
Ha.
I've lost my internet connection. Okay. I'd like to call on Dr. Anita Nete, madam, to say a few words. Nete, madam, is.
I don't think she has joined yet.
He isn't joined, yeah.
I'd like to call on Dr. Vika. I think Karni sir has also not joined.
No.
Recording in progress.
Parna madam has also not joined. I think we can start with the cases.
We can start with the CME. I mean, webinar.
I'd like to call on Dr. Radha madam to say a few words about today's program.
Yes. Thank you very much, Dr. Rohit, Honorable Secretary of our ISA Amravati branch. It's indeed a great opportunity for us, the ISA Amravati branch, to conduct a webinar at state level with interesting topics related especially to regional anesthesia. Regional anesthesia had always been fascinating as over the years, it has evolved from landmark guided blocks to PNS guided to USG guided, and now even fluoroscopic guided blocks are being given. But at a place like Amravati, where there ain't many corporate hospitals, the small nursing homes and operation theaters maximum cater to almost 80% of the population here. So we won't be provided with USG machines for blocks if it is only a orthopedic setup or a plastic OT setup. So here and at periphery in my district like Morshi, Varud, Paratwada, we still practice landmark guided blocks. And we are very much delighted to have the experts in this field for this topic. And also the office bearers of SAMS, who all can guide us in our work and also give us an insight to the advances in regional anesthesia around the globe. Thank you very much.
I'd like to call on Dr. Monica Patil Madam to introduce Dr. Sandeep Diwan sir.
I
Dr.
think
Monica
Dr.
Patil Madam.
Rohit Sandeep Diwan sir is yet to join. So
Dr. Cham
whenever
sir
he
will come.
joins, yes.
Okay. I will give the introduction of Dr. Chandrasekharan Cham sir. Dr. Chandrasekharan Cham sir is a faculty for regional anesthesia and pain since last 25 years and is a chief consultant in anesthesiology and pain medicine at KIMS Kingway Hospital and is assistant professor at JNMC Savangi Wardha. He is our GC member, National ISA 2326. Cham sir has held many posts in various prestigious organizations and conferences. He has been president West Zone ISA in 2018-19, Vice President Maharashtra State ISA 2022. He is also Vice President for Indian Society of Study of Pain, National 2022-2023, and President of ISSP Nagpur branch. He has been organizing chairman for ICRA Pain Help in Nagpur in 2019. He is the founder executive member of AORA India, that's Academy of Regional Anesthesia. He has been GC member to ISA Maharashtra for 3 terms. He has various awards to his credit, which few are as PhD scholar in pain Savangi was awarded to him in 2022. He has done fellowship in Ascalab Academy and Delhi Pain Management Center under Professor Dureja and Dr. Gautam Das sir. He has been awarded Srimati Sushila Seth Memorial Award in 2016 by ISA Nagpur and President Appreciation Award in 2021. He has delivered 3 orations at the state and national level and conducted many live workshops in pain and regional anesthesia. We at Amravati Society of Anesthesiologists were very fortunate to have Cham sir as our installing officer for our body. He gave us the consent in one request. He was very cordial, humble, and very cooperative. I find me always available to most of the members whenever required for any kind of difficult situations. He's very helpful personality. We at Amravati anesthesiologists are very fortunate to have Cham sir today as an expert in the regional anesthesia webinar. I, on behalf of ISA Amravati and SAMS, welcome Dr. Cham sir.
Thank you.
Thank you. Now I would like to introduce the moderator for today, that is Dr. Ashish Bhattar, who is sitting with me. He has done his MBBS from GMC Nagpur, MD from IGGMC Nagpur, fellowship in critical care medicine, and has worked as a junior consultant with Sunil Pandya sir, Hyderabad, and registrar to Dr. Bala Venkat sir, Coimbatore. Presently, he is working as in private for more than 13 years. Special interest is critical care, obstetrics, trauma, and perioperative management of high-risk patients. Regularly, mediator, and active volunteer for Art of Living Foundation. That's a different kind of character for him. So, Dr. Ashish Bhattar, please.
Thank you very much, sir. Basically, though I am being called as moderator, basically in front of Cham sir and seeker.
You are here to learn as things. So, we start with the speakers. First speaker is Dr. Anup Panaskar. Anup, you are ready?
Yes, sir. Good evening, sir.
Good evening. Anup has done his DA and DNB, DA from GMC Nagpur and DNB from JLN Hospital and Research Center, Bhilai, Chhattisgarh. Worked as a medical officer in Super Specialty Hospital at GMC Nagpur for Uro and Neuroanesthesia cases. Presently, he is working at Dr. Panjabrao Deshmukh Memorial Medical College. Consultant anesthesiologist in Sunshine Military Specialty Hospital at Amravati. Over to Anup Panaskar. Dr. Anup, you may start.
Good evening, sir. Good evening, respected seniors and dear colleagues. Myself, Dr. Anup Panaskar. Today's topic is landmark guided blocks for wrist fracture and humerus fracture. So my screen is able to see everybody?
Yes, we are able to.
Yes.
Okay.
Yes.
So this is our today's outline. Its first is introduction, then brachial plexus blocks and its types, technique, wrist block, complication and references. Just a minute, ma'am.
Yeah. Anup sir, can you make it full screen?
Yes, ma'am. Just a minute.
Yes, we can see now. Full.
Okay, thank you. So we are starting here from the brachial plexus anatomy. A little bit brief anatomy. A brachial plexus is an arrangement of nerve fibers running from spine forward, the ventral ram of the lower cervical, and the upper thoracic nerve roots. It includes from above the fifth cervical vertebra to underneath the first thoracic vertebra, C5 to T1. It proceeds through the neck, the axilla, and into the arm. The brachial plexus is responsible for the cutaneous and muscular innervation of the entire upper limb. The trunk passes laterally and lies around the subclavian artery while passing over the first rib to enter the axilla between the clavicle and scapula. Behind the clavicle, each trunk and splits into an anterior and posterior division. These recombine to form the posterior lateral medial cords around the axillary artery. The upper root, that is C5 to C7, tends to stay lateral. The lower root C8 to T1 tends to stay medial, and all roots contribute the posterior cord which give the radial nerve. Here it's a diagram of brachial plexus. Here we are able to see there is root C5 to T1. There are then trunks, then there is division, and there are the cords. And there are lateral cord, posterior cord, medial cords, and their respective branches. So brachial plexus blocks, and it has different approaches for the landmark guided. So we have chosen depending upon the site of the proposed surgery, and for that the method of needle localization, that is paresthesia, or if nerve stimulator is available, then with that nerve stimulator we will also obviate to needs to for the paresthesia. Then approaches for the brachial plexus blocks, it has mainly four approaches: interscalene, supraclavicular, infraclavicular, and axillary. So we will talk on the especially interscalene, supraclavicular, and axillary blocks. Interscalene block, it is developed as an alternative to the supraclavicular approach to brachial sheath. It has advantages that can be used for proximal block, is required for shoulder surgeries, can be performed for arm surgeries also. Pneumothorax, which is a risk in another blocks, that is supraclavicular and axillary, here that risk is reduces. Landmarks are usually very clear even in stout patients. Disadvantages of the interscalene blocks are essential to elicit paresthesia. Supplementary ulnar nerve block may require. Common but serious side effects are spares lowest branch of C8 and T1, which innervate the ulnar forearm, indicates shoulder, humerus, and forearm surgeries. Here is my case, which is a fracture of surgical neck of humerus. For that,
Anup, we are not able to hear you, Dr. Anup.
Anoop's internet connection. There's some problem with internet connection of Anoop.
Acha, is Dr. Anup also with you all, or he's
No,
safe?
no, he's not with us.
Okay, okay.
He's in Pune.
Uh-huh. Um, Radha madam has his presentation, no? But
Yes, Radha is there.
Rohit,
Yes.
I'm trying to call him also.
able to see Dr. Anup.
Yes, I'm trying to call him, but his phone is not getting connected.
You want to call him, Radha madam?
I'm trying to call him. Otherwise, if Anup, now I am able to see him. 1 second, I will call him. If he is able to receive the call, then it's okay. Otherwise, we will move on to Rohit Hadgavkar in the meantime, because we cannot just wait, no? That's
Yes. Anoop has joined, but his screen and things are not there.
I think Dr. Rohit Ganadiwal, Rohit Hadgavkar is there. Should we ask him to present?
Rohit,
Dr. Rohit, you are
Hadgavkar,
not
are you
audible.
ready?
Yes, yes, I am ready.
Rohit Hadgavkar, you are able to hear me?
Yes, can you hear me, sir?
Yes. So, sorry for the trouble. I'd like to call upon the second speaker today, that is Dr. Rohit Hadgavkar. I'd like to introduce him. He has done his MD Anesthesiology from BJMC Pune, worked for various projects like comparison of 2 different doses of dextromide with lignocaine in alleviation of pain on propofol injection. He has publications to study in the relationship between spot urinary albumin to creatinine ratio and 24 hours urine protein in type 2 diabetes patients, and association of proteinuria with diabetes, retinopathy, hypertension, hyperglycemia. This was a cross-sectional study. He has won a first prize for paper presentation at Geriatric Society of Conference in 2018. Came amongst the first top 7 students selected for ISA Neon Island Fellowship at national level conference. Dr. Rohit Hadgavkar, you may start, sir, please.
Thank you very much for kind introduction, sir. I'll just share my screen. Is it visible, sir?
Yes, you can.
Good evening, everybody. I'm Dr. Rohit Hadgavkar. I'm working as panel consultant anesthesiologist at Government Super Specialty Hospital, Amravati. And I thank Radha Madam, Rohit sir, and the office bearers of SAMS for giving me this opportunity. Topic of my discussion for today's seminar is landmark guided blocks for lower limb surgeries. So the rationale of having this topic is usually the mainstay of anesthesia plan for lower limb surgeries is subarachnoid blockade. The peripheral nerve blocks forms the mainstay in cases of a compromised patient, and mainly to provide perioperative analgesia, which will be supporting to our subarachnoid blockade in these patients who are supposed to be operated for lower limb cases. So I'll keep my scope very limited to lateral femoral cutaneous nerve block, fascia iliaca block, and femoral block. All these peripheral nerve blocks, they are given either landmark guided, as Dr. Anup has very well said. They can be given by blind block through landmark guided method, or peripheral nerve stimulators or with the help of ultrasonographic assistance. So, as I've said, my scope will be these 3 blocks for today's presentation. For all these blocks, my specific requirement will be a blunt or short beveled needle in antiseptic solution, 1 to 2 ml of lidocaine for skin infiltration in the awake patient, and around 30 to 40 ml of long-acting local anesthetic agent like 0.5% bupivacaine or 0.2 to 0.75% of injection ropivacaine. The dose of the local anesthetic agent should be titrated according to the weight of the patient, and in most of these blocks, the concentration of a drug can be compromised for volume of the drug, as mainly these are volume blocks. So for contraindication of all these blocks, as it is common to everybody, every block, patient's refusal, anticoagulation, inflammation or infection over injection site, and allergy to local anesthetic. Complications of these blocks can be intravascular injection, local anesthetic toxicity, temporary or permanent nerve damage, infection, block failure, or allergy to any of the preparation used along with the local anesthetic. So here comes my first case. It is 82-year-old female patient coming to Government Super Specialty Hospital Amravati with raw area over dorsal aspect of right foot and was posted for split thickness skin grafting. She was a known case of hypertension, type 2 diabetes mellitus, in ischemic heart disease, and PTCA was done in LAD and left circumflex artery in 2017, and she was on antihypertensive medication, oral hypoglycemic agents, and blood thinners. Blood thinners were stopped 5 days prior to the surgery, and recent 2D echo was suggestive of global hypokinesia with ejection fraction of 26%. She had this non-healing ulcer resulting in raw area, so was posted for split thickness skin grafting. Rest of the investigation normal limits. So primary anesthesia plan for this patient was for this patient was graft was supposed to be harvested from opposite limb, and the wound was on a dorsum of foot. So two methods were employed: left lateral femoral cutaneous nerve block for graft harvesting, and right ankle block for the wound site analgesia. So I'll be concentrating on lateral femoral cutaneous nerve block as we gave both the blocks, but ankle block will be discussed separately and thoroughly by my colleague. So lateral femoral cutaneous nerve block. So here is the anatomy of the block, anatomy of lateral femoral cutaneous nerve, and ASIS forms the basic landmark for this block. So as we can see, in lateral cutaneous nerve of thigh supplies to the anterolateral aspect of the thigh, whereas anterior femoral cutaneous nerve supplies mostly the anterior part of the thigh. So this block is generally considered for skin grafting on from a skin harvest from lateral aspect of the thigh, and can be also used as diagnostic tool for meralgesia paresthetica. It is the neuralgia of the lateral femoral cutaneous nerve of thigh. So as I've said, anterior superior iliac spine is the basic anatomical landmark. The lateral femoral cutaneous nerve emerges from the lateral border of the psoas muscle and crosses the iliacus muscle obliquely towards the anterior superior iliac spine, where it supplies parietal peritoneum of the iliac fossa. The nerve then passes into the thigh behind or through the inguinal ligament, variably medial to the anterior superior iliac spine, and through the tendinous origin of the sartorius muscle, dividing into anterior and posterior branch. Anterior branch becomes superficial, about 10 cm distal to the anterior superior iliac spine, supplying innervation to the skin of the anterior and lateral thigh as far as the knee. It connects terminally with the cutaneous branches of the anterior division of the femoral nerve and the infrapatellar branch of the saphenous nerve, forming the patellar plexus. So as it provides sensation to anterolateral aspect of the thigh, in some of the patient, however, the nerve can provide surprisingly large innervation territory of the anterior thigh. So before starting the skin harvest, we have to outline the territory which is being anesthetized, and then only start harvesting. The patient is in supine position and anterior superior iliac spine is palpated and marked. A 20 to 25 gauge needle is inserted 2 centimeter medial and 2 centimeter distal to the anterior superior iliac spine. The needle is then advanced until a loss of resistance or a pop is felt. Because of the fascia give is not consistent and its perception may vary among practitioners, local anesthetic is injected in fan-shaped fashion both above and below the fascia lata from lateral to medial. Because no larger vascular structure or organs are nearby, block of lateral femoral cutaneous nerve comes with minimum risk and complication. So coming back to the cases, the patient tolerated the procedure well, vitals were maintained in acceptable range throughout the procedure, and there was no need of any other analgesic agent to be given to the patient, and the procedure went off well. Now coming to the case second, it was a 60-year-old male patient coming to a private hospital with subtrochanteric extension. He complained of pain and difficulty in movement of right lower limb. He is known case of hypertension and he was on tablet telmisartan 40 milligram OD. His effort tolerance was good and rest of the investigation were well within normal limit. Plan of anesthesia, the primary plan for this patient was subarachnoid blockade with injection ropivacaine 0.75% heavy 2.6 ml with additive injection buprenorphine 60 microgram. But to facilitate the position, we had two options, either to go for fascia iliaca compartment block or femoral nerve block. So let us come to fascia iliaca compartment block first. This is the fascia iliaca compartment which we are concentrating now on. So after the skin and subcutaneous tissue, there is this sartorius muscle, then external oblique muscle and iliacus muscle. Covering of the iliacus is the fascia iliaca, and this is the compartment in which we are supposed to deposit the drug. So this fascia iliaca, its location, it spans from the lower thoracic vertebrae to the anterior thigh. So for indication of this block is patient with fractured neck or shaft of the femur. It acts as an adjuvant analgesic for hip surgeries, above knee amputation, analgesic for plaster application in children with femoral fracture, analgesia for knee surgeries when combined with sciatic nerve block, and lower leg tourniquet pain during ABIC surgery. The landmark for this block are the anterior superior iliac spine and pubic tubercle. We draw a line that is ASIS and pubic tubercle of the same side and divide it into three parts. And we mark the point, a point which is 1 centimeter caudal of lateral and middle third, and this is the injection entry point. It's a very low skill method to provide intraoperative analgesia to patient with painful conditions. As I've said, in this case it is the intertrochanteric fracture with subtrochanteric extension where positioning is difficult. Usually the nervous supply of lower extremity is by 4 major vessels: sciatic nerve, femoral nerve, obturator nerve, and lateral femoral cutaneous nerve. Out of these 4, 3 are from lumbar plexus and sciatic nerve is from lumbosacral plexus. This fascia iliaca compartment allows distribution of local anesthetic of sufficient volume to spread to at least 2 of the 3 nerves which supply medial, anterior, and lateral thigh with single injection. That is the beauty of this block, and that is the reason why it is so widely used. Obturator nerve is usually not convincingly involved in this block. So as I discussed, this is the ASIS and pubic tubercle line connecting the two. The injection point is 1 centimeter distal to the connection between lateral and middle third of this line, whereas middle third and medial third, here usually lies the femoral artery. So while injecting or while giving the piercing the skin, always be palpating the femoral artery and our injection site should be 1.5 to 2 centimeter away from the femoral arterial pulsation. So as I've said, we should identify the landmark, palpate the ipsilateral femoral pulse, pierce the skin at right angle. Once the skin is pierced, then the angle is 60 degree and the tip should be directing cranially. We should keep the needle in the sagittal plane and advance the needle through the two distinct pop. First pop coming from the fascia lata and second from fascia iliaca. After the latter, the pop of fascia iliaca is usually subtle. So after these two pops, we should decrease the angle even further to 30 degree and advance just 1 to 2 mm inside. Aspirate before injection, and we should keep on aspirating every 5 ml injection of the drug. Its risk of intravascular injection, local anesthesia toxicity, and mechanical nerve damage are extremely low, as there are no major organs present near this near the territory of this block. So, but risk of local anesthetic toxicity is highest within first 15 minutes of injection, which makes close monitoring mandatory for this patient. So, in short, the fascia iliaca compartment block is guided by landmark. It is inexpensive, safe, and easy to perform. The location of fascia iliaca compartment block is injection is protective. It delivers effective analgesia. But as it's a volume block, we give large volume. Usually, then we compromise on the concentration of local anesthetic which we use. So it does not give anesthesia, but it's an awesome anesthetic analgesic agent. Large volume of local anesthetic is required to achieve good spread, and blockade of obstructor nerve, as I've said, in this single injection is best unreliable. Now coming back to the femoral block, femoral nerve is the largest branch of the lumbar plexus, and it arises from the ventral rami of second, third, and fourth lumbar nerves. The femoral nerve lies outside the femoral sheath and is covered by two facial layers, the fascia lata and fascia iliaca. The femoral vessel, however, are only covered by single layer, that is fascia lata. Thus, this nerve actually lies in a different tissue plane to that of vessels. So dermatomal innervation, it gives to anterior-medial aspect of the thigh, knee, and medial border of the leg up to the medial malleolus via saphenous nerve. Myotomal innervation, it gives myotomal innervations to sartorius, quadriceps femoris, iliopsoas, and pectineus muscle. Osteotomal innervations are anterior wall of hip joint, anterior aspect of the femur, and anteromedial wall of the knee joint. So indication of femoral block. Femoral block alone can be used for skin graft or muscle biopsy from the anterior aspect of the thigh. In combination of sciatic and obturator nerve, it can be used. Obturator nerve block, it can be used for knee surgeries. In combination with sciatic and popliteal block, any procedure of the lower limb or foot, like amputation, can be done. And it provides perioperative analgesia in fracture, neck, or shaft of femur, which can be useful to facilitate patient positioning prior to neuraxial blockade. And that is precisely the reason why we are discussing this this block in this particular case. So the procedure is operator should stand on the side, which has to be blocked. Clean the skin with antiseptic solution, local infiltration with 1 to 2 ml of lignocaine in awake patient. Mark the inguinal ligament, palpate the femoral pulse and mark it. Needle entry point should be 1 to 1.5 centimeter lateral to the artery to the midpoint of the inguinal ligament. The femoral artery should be palpated with non-needling hand throughout the block, and we should stay away from the femoral artery, but as close as possible to the inguinal ligament, because femoral artery divides into two, which is the anterior superficial and posterior deep branch. It divides into two just distal to the inguinal ligament. So there are chances if we can miss one of the branches if we take needle prick away from the inguinal ligament. Insert the needle through the skin. Direct the needle cephalate at an angle of approximately 30 to 40 degrees. The nerve is rarely deeper than 3 to 4 centimeter from the skin. Two distinct pop may be felt. Aspirate the syringe to exclude extravascular placement. Inject 1 ml of local anesthetic. If there is high injection pressure or if there is any pain on injection, we can just remove a little, and then remainder of the local anesthetic can be injected, aspirating after every 5 ml, and a total 20 ml dose is usually sufficient for the patient. As I have said, it should be combined with either sciatic or popliteal block for providing analgesia for above or below knee amputation, for plaster application for the in children with femoral fracture. One precaution which we need to take is in obese patient, retraction of abdomen is necessary to facilitate palpation of femoral artery and performance of this block. So the attendant should be standing in opposite direction, holding the abdomen, retracting the abdomen of obese patient with both the hands. So in short, it's one of the easiest peripheral nerve block, as mostly the femoral nerve is usually superficial and the landmark are easy to identify. But it as a sole technique for it cannot be used as a sole technique for various procedures. But as I've said, it can be combined with other sciatic nerve, popliteal, obturator nerve blocks to provide a good analgesia. So coming back to the case, we gave for this patient, we used fascia iliaca compartment block. Patient could sit with it after 10 minutes. We gave central neuraxial blockade with injection ropivacaine 0.75% heavy with injection bupivacaine 660 microgram. A procedure was completed within 1.5 hours. The procedure was uneventful. Vitals were maintained in acceptable range, and we need not use any other analgesic agent, not for positioning or throughout the procedure as well. Other blocks which are involved, which are for lower limb surgeries, are lumbar plexus blocks, sacral plexus block, sciatic nerve block, genicular nerve block, adductor canal block, popliteal block. But these blocks, there are two reasons why I did not cover these blocks. One is landmark guided block. Giving these blocks landmark guided is difficult, and most of these blocks are nowadays conducted under sonography guidance. I'm not privy to, as Radha Madam has said, in our setup, we do not have access to these sonography machine. And I have not done those blocks, so I did not cover those blocks, sir. So the key safety points for all these blocks is always perform the block in an appropriate setting using suitable equipment with a trained assistant and resuscitation facilities at hand. Always prepare your patient correctly, ensuring informed consent, appropriate monitoring, and intravenous access. Never try to inject a local anesthetic dose if blood has been aspirated, the patient complains of pain, or if there is resistance to injection. If symptoms of local anesthetic toxicity develop, stop injecting, call for help, and follow the AAGBI guidelines on the management of severe local anesthesia toxicity. As with any peripheral nerve block, be prepared for block failure and have a backup plan. Always ensure you are within a safe dose of local anesthetic. Thank you. Thank you very much, everybody, for giving this opportunity. And I raise my hand. Thank you.
Thank you, Dr. Rohit Hadgavkar. Dr. Ashish Bhattad, if you have any questions, please come up with your questions. Dr. Ashish Bhattad.
Dr. Rohit, you want to welcome Dr. Sandeep Diwan sir?
Yes, sure. Yes, he has come. Thank you, Dr. Diwan sir. Welcome, Dr. Diwan sir, to our today's webinar. I'd like to call upon Dr. Monica Patil madam to introduce Dr. Sandeep Diwan sir. Dr.
Good
Monica
evening,
madam.
everyone.
Yes,
Good evening, everyone. Dr. Sandeep Diwan sir, who has carved a niche for himself, especially in the domain of regional anesthesia, is a consultant anesthesiologist, pain physician, the academic director, and also heads the research department of anesthesia at Sancheti Hospital for Specialized Surgery, Pune. He was the former president and is the academic director of the prestigious Academy of Regional Anesthesia, AURA. He is also the editor of International Journal of Regional Anesthesia, which is an official publication of AURA. Dr. Sandeep Diwan sir completed his MD Anesthesia from GMC Miraj in the year 1993, in which he was a university topper. Since the past 3 decades, Sir has been practicing in anesthesia and with a special interest in regional anesthesia. Success does not come by chance. You have to strive for it. Dr. Sandeep Diwan sir is a life example of this. Sir started his career from Sangli, and then there were days when he used to go every week to Pune just to learn the anatomy and the course of nerves plexus on human cadavers, the mastery of which we all know is a foundation of regional anesthesia. Dr. Diwan sir has done innumerable presentations at the state, national, and international conferences like ISACON, Ahmedabad, Coimbatore, Bhopal, etc., Asian and Oceanic Society of Regional Anesthesia, New Delhi, European Society of Pediatric Anesthesia, Germany, ASPA, Vietnam, Mysore, Dubai, to name a few. Well, the list is endless and would require a special webinar to cite the same. Dr. Diwan Sir is not only just a national faculty, but also an international faculty in the field of regional anesthesia and USG guided blocks, and has successfully conducted workshops in Visacon, Isacon, and Aura India, and also in Singapore, Nairobi, Thailand, Bali, Turkey, etc. Sir has also been invited as a faculty in the World Congress of Regional Anesthesia in Paris in 2023 and in the upcoming World Congress of Anesthesiologists to be held in Singapore in 2024. Sir is also an associate faculty of the New York Society of Regional Anesthesia, NYSOTA. To add to his immense armamentarium, Dr. Diwan Sir has enormous numbers of both national and international publications to his credit. He has authored many chapters in various books like Textbook of Pain Management, Principles of Anesthesia, the Textbook of Orthopedics by Dr. G. S. Kulkarni also includes 3 chapters which is written by Diwan Sir. Dr. Sandeep Diwan Sir's book, Cadaveric and Clinical Anatomy for Regional Anesthesiologists, which is soon going to get published, is going to be a boon for all the practicing anesthesiologists. Dr. Sandeep Diwan has received many uncountable awards at all levels, state, national, and international, but it gives us immense pleasure to announce that he received his first Best Paper Award at the state level, which was held in Amravati in the year 1998. And sir, it is a matter of great pride for all of us here that you are today present as an expert for the webinar on regional anesthesia hosted by the Amravati Society of Anesthesiologists.
खूप गरम
Sir
वाटलं
is also
तर तुमच्याकडे पंखा वगैरे पण मिळून जाईल ना पंखा कूलर
Sir is also the recipient of the Lifetime Solapur Alumna Award in 2019 and the Ranjit Academy Award in 2020. My introduction of Diwan Sir would be incomplete if I don't mention that in spite of being such a magnanimous personality in the field of anesthesia, he is an absolute humble and a down-to-earth person who is always ready to help and guide others with a smile on his face. I welcome you, sir, for this webinar.
Thank you, Monica madam.
Thanks for that introduction. Thank you very much.
Ashish, you have any questions?
Yeah. Welcome, Diwan sir. We are eagerly waiting for you.
The first topic.
Yeah. So Rohit has wonderfully covered the lower limb blocks. Most of the blocks mainly we are using for the analgesia purpose. Sir, my question to Divan sir will be, most of the times in orthopedic surgeries, we encounter the IT fractures, intertrochanteric fractures, and where the patients are old, most
एस्टिमेट देऊन द्या आम्हाला दादा
most times they are old on. Sorry for the disturbances.
पाहिजे का राजेश
Okay. Please, I will ask Dr. Kasturi sir and N. Deshmukh sir to please unmute them, to mute themselves.
बोलू आमचा एकदम जवळचा आहे
Ganesh sir, please mute Kasturi sir.
Ganesh,
Sorry for the inconveniences. I'm audible now?
Yes, go ahead.
Yeah. Sir, many times we encounter the old patients who are morbid, mostly on the dual antiplatelet agents, and they're having the low ejection fractions. In these patients are with IT fractures, intertrochanteric fractures. So, in our the guidelines say that we need to wait for around 5 to 7 days for antiplatelets to stop. So, my first question is it a routine practice everywhere? Because orthopedicians always specialize us to not to wait for that much period of time. Second thing, they are not ready for the GA. Third question, that thing what I want to ask is there any combination of regional blocks where we can go with that instead of neuraxial anesthesia?
So, first of all, let me congratulate Amravati branch for coming up with this particular webinar devoting to regional anesthesia. And also to one who just presented this femoral and fasciatica block. Now, considering the particular octogenarian patients, now things have changed because we use a lot of ultrasound, but that doesn't change the scenario of the anticoagulation. Now, for me, because I have gone through a couple of articles that mention that the levels of clopidogrel and its metabolite they are reduced to almost less than 50%. So as the days go by, and at third to fifth day, it is almost like less than 50%.
मध्ये 2 दिवस नाही तर काढून पुन्हा लावण्यात ते
Ganesh from Geneva, are you not there? Varsha madam, Ganesh madam.
Hello, madam.
Please mute ना, immediately mute करशील जे कोण बोलतायत त्यांना.
Yes, yes.
Sorry.
Answer, please continue. Divan sir.
Divan sir, you want to continue?
Yes, can I continue?
Yes, continue, sir, please.
Yeah.
Thank you.
So things have changed as the ultrasound has come into clinical practice, but that doesn't change in the periphery. So I have worked in the entire spectrum where I have worked in the periphery and then now into the corporate hospitals where we have ultrasound at our disposal. But when the patient arrives, the best part is to give a fasciatica block or a femoral nerve block, as has been rightly mentioned by the faculty who delivered this lecture. The volumes of local anesthetic, yes, they are what is a larger volume in fasciatica because large compliance, but it will act for a short duration. While the femoral nerve block, it gives off the articular branches but does not cover the lateral aspect of the thigh. Of course, it's good for the preoperative analgesia and to make the patient sit for the surgical, for the anesthetic procedure. Now, neuroaxial anesthesia, regarding the clopidogrel activity, it usually diminishes from third day onwards. Fifth day and seventh day, it's almost very much less than 25%. So I think what I do in my clinical practice, I'm not recommending this, but you can start initiating this practice where the clopidogrel at third day, the metabolites of this clopidogrel are less than almost 50% with a relatively high platelet activity. So that is a possible scenario where you can do it on the third day. But general anesthesia, as you have mentioned, I think it's not a contraindication because many of as you rightly said, that the surgeons pressurize us to go ahead with the anesthesia and surgical procedure. So if you have a backup intensive care, a good intensivist and a cardiologist, and I think most of you are working in high specialty, super specialty hospitals, which are also government hospitals. I think you have got access to all this particular group of specialists. So I think general anesthesia is not a contraindication. You can always combine it with a block. Our surgeons are fortunately very fast. So we do not usually we do not postpone or cancel cases just for the sake of it, unless the patients have a few things. One is hemoglobin less than 8. Second thing is sodium, serum sodium. If it is less than 120, but 120, and if the patients are asymptomatic and it's a chronic hyponatremia, we go ahead with it. Then the third thing is the serum creatinine levels. Most of the patients, you have to keep in mind the rule of 40%. So 40% of the intertroph fractures, they come with low hemoglobin, high serum creat, and altered altered sodium levels. So this thing you have to keep it in mind. And the fourth is cognitive dysfunction, very high in patients who are in severe pain, dehydrated, and previous cognitive dysfunction. So all these things keeping in mind, regional anesthesia technique in our institute has definitely made the post-operative delirium to decline. So we are finding it in a very less percentages nowadays. So this is my take over whatever your questions that I think I have answered most of them.
Sir, just one question. Is there any anesthetic technique with the use of regional blocks other than neuroaxial blockade for these hip surgeries?
Do you mean to say interfacial pain blocks? Or do you mean to say the lumbar plexus and sacral plexus blocks?
Yeah, can we combine any of the regional techniques? Like recently, I encountered one patient who's suffering from multiple sclerosis with a chronic secondary type, and she is having severe restrictive disease of the pulmonary of the lungs. Now she was not as the literature mentioned that spinal is a contraindication in such patients, and the pulmonologist was not ready to for acceptable for the GA. So in such patients, I gave epidural. But is there any regional techniques where which we can be combined, which we can use in combination while anesthesia for hip surgeries?
So apart from, this case proves that regional technique would definitely help. Apart from that, multiple sclerosis, I can definitely tell you that it could be a relative to absolute contraindication depending upon the severity of the disease. And of course, the restrictive lung disease makes it very difficult for a general anesthesia, but it doesn't mean that you cannot give a general anesthesia. We have given general anesthesia in restrictive lung diseases, and we have come out of it. Patients have come out of it, but they had a contraindication for regional as well. So I think in this case, lumbar plexus and sacral plexus, but keep it in mind that in patients with anticoagulants or low molecular weight heparins, again, it's a big no, because these are deep situated blocks and you keep needling all the time. And then if you don't get it, you get frustrated, you needle every time, and then you create a lot of hematomas in the which you never encounter this. Even with ultrasound, you might be not able to get that. So even with the ultrasound in place, this block would be a contraindication and anticoagulation. But lumbosacral plexus, yes, because I've been doing it for a long time. Chandrasekhar Cham and myself, we have been doing it for now decades. So I think this is the one block that can help you to come out of it. Yes.
Thank you. My next question will be for Dr. Cham sir. Cham sir, as Dr. Diwan sir said, that Cham sir is using lumbar plexus blocks since decades. Okay, sir, can you elaborate the intricacies of lumbosacral block, lumbar plexus block when we are doing by landmark techniques?
We have started with landmark technique, but I will prefer with nurse stimulator. If you're using landmark technique, the actually anatomical landmark is the intercostal line and the posterior superior iliac spine, just line parallel to the interspinal line, and the line intersecting this intercrystal line will be the point of injection. You have to just go perpendicular to that point, and once you hit the transverse process, you are just near to the lumbar plexus. You have to go slightly caudal or cephalic. Once you get quadricep paresthesia or contraction, then you have to inject the drug. It's a large volume block, so we need about 25 to 30 ml. The intricacies in that, it should be once you hit the transverse process, then you are in a proper position and you have to just tilt the needle towards cephalic or caudal direction to get the lumbar plexus. Is it okay?
Yeah,
Ashish?
thank you, sir. Thank you very much, sir. One question for Dr. Diwan, sir. Sir, any combination of regional blocks which can be sufficient for patellar surgeries or the knee surgeries?
So in patellar surgeries, it's chiefly innervated by the femoral nerve and its branches, cutaneous branches, the intermediate and the medial, and the saphenous branch, which gives the infrapatellar nerve that forms a plexus. So it's entirely innervated by the femoral nerve, except the lateral part, the lower pole, which is innervated by the genicular branch of the common peroneal. So I think in the past we used to actually inject into the common peroneal and try to anesthetize, but that was not required. So then we started asking the surgeon to infiltrate just the lower lateral pole of the patella, which was in fact more helpful in this case. And interestingly, in one case of severe patellar pain secondary to metastatic patella, that's quite rare. In that case, just the femoral nerve block, it helped. So, of course, it does cause quadriceps weakness. We did not give any neurolytic block, but then we gave the infrapatellar nerve block and we did a radiofrequency lesioning, and that really helped. So the entire patellar plexus, which is formed by the infrapatellar nerve, it always innervates the undersurface of the patella, while the superficial is all by the cutaneous nerves of the femoral nerve.
Sir, there are so many questions that due to time constraints, we'll move to the another topic. I will hand over to the Rohit Ganeriwal, sir, to introduce the next speaker.
Thank you, Dr. Ashish. Thank you, Diwan sir. Thank you, Cham sir. We move on to the third speaker today, that is Dr. Radha Savdekar madam. I'd like to say a few words about Dr. Radha Savdekar madam. She has done her MD anesthesiology from Sion Medical College, Mumbai. She is a gold medalist in anesthesiology from Mumbai University, working at presently as anesthesiologist and intensivist in Amravati in Suyesh Trauma Hospital since last 20 years. She is ICU in charge at Savdekar Hospital and professor at VYWS Dental College. She has 4 national and international publications to her credit. Recently, one research article has been included in the chapter in textbook of infectious diseases. She is instructor of American Heart Association since 2018 for BLS and ACLS. She has been a faculty speaker for many conferences, not only in anesthesia but also in surgical conferences, Massicon and Vasakan in the orthopedic conference. She is presently the president in ISA Amravati. The branch under her leadership has been awarded 2 prizes for public awareness and membership drive at ISACON Pune 2023. Her extracurricular activities: badminton state champion in 2018, successfully completed many half marathons and cyclothons. Radha madam, please start on.
Yes. Thank you, Dr. Rohit, for the kind words. Is my screen getting seen? No.
Madam, screen sharing is not available.
Yes, 1 second. I will do it.
Yes.
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 Yes, madam.
Enlarged slideshow. Yeah. Well,
Yeah. Okay. So my today's topic is anesthesia for percutaneous endoscopic lumbar discectomy. This is a very upcoming surgery, and it has been recently started in Amravati since the past 1 year. Initially, we only used to know about the conventional method of laminectomy and discectomy done for prolapsed discs. And later on, it was also introduced as microdiscectomy, which was also done with a very minimally invasive procedure. But nowadays, percutaneous endoscopic lumbar discectomy is very much into vogue, and it is being propagated as a daycare surgery. I will move on to the anesthesia part of it, but little bit of surgery and the steps involved should be known to us, because it is going to be a really challenge as to how to maintain the patient calm and quiet in prone position for almost 1.5 to 2 hours. So whenever the surgeon, it is basically a keyhole surgery. You can see on the screen, the patient lies in a prone position, and through a small opening, the surgeon first introduces the needle, and over it, through the railroad techniques, he introduces a dilator, and through that a scope is being introduced. These are the lateral view and the AP view, which you can see very well that the dilator has reached till the L5S1 vertebra into the interspace, and they are very well negotiating it with the disc. So the most important structures which the surgeon is going to go through is known as the Cambin's triangle, because Cambin was the first person who introduced like how to put in a scope. The basic advantage of this technique was that for a small disc to remove, initially the surgeons had to remove the lamina, everything, and the incision was to a very big incision to be given. The patient who used to be given general anesthesia, and there used to be a lot of contraindications also in high risk patients in whom general anesthesia used to carry a high risk. So this technique was introduced. So here, the most important structure is the Cambin's triangle, which is formed by the superior end plate of the lower vertebra. Laterally, we have the exiting nerve root of the previous level, and then this is the transversing nerve root. So here it is seen as a big thing, but actually this is a small 5 millimeter space through which the surgeon is going to negotiate his scope. So this the very fact that the removal of disc, it was like, you are going to catch a rat by digging a big mountain. So it is same way, if you have to remove this disc, why to remove the lamina, why to go inside through the conventional method and remove, when very well we can start by just negotiating through here, through the laterally through the disc, and remove the disc with the scope. So this is basically the outlay of the operation theater, where the anesthetist stands at the head end. The surgeon is standing laterally. Now, if the patient is having unilateral symptoms, like suppose only the right side radiating pain, or the disc is right-sided prolapse, the surgeon will stand on the right side and try to introduce the scope through the right side only. If it is a left side, the surgeon may stand on the left side and the C-arm will come on the opposite side. The basic advantages of PLD are definitely the hospital stay is very small, because the surgeon is advocating it as a daycare procedure. It has to be done under local anesthesia, where the patient is awake, arousable, and aware about the surroundings. He is able to cooperate with the surgeon also, because the surgeon needs to interact with the patient on table. So this will also help in early rehabilitation. GA is definitely to be avoided for all sorts of reasons. For high-risk patients, this is a very good approach, because if a patient is having supposedly ejection fraction 20%, who is having a single level disc and is really in pain, in such case patients also PLD can be performed very well. It is a minimally invasive procedure which is alternative to microdiscectomy. PLD also results in similar surgical outcome as compared to the microdiscectomy or open procedures. It is a good option even for revision spine cases having recurrent disc, where the person might have undergone a conventional method discectomy before, and now open surgery because of adhesions is difficult. So even in those patients, PLD can be indicated. The basic indications of these cases, that is, though it is a surgeon's domain to decide which patient to expose for PLD, which patients to be done microdiscectomy or any spine fixation. But one thing is for sure, that a single level disc where the disc is located in the foramen, as you can visualize in this, basically there is a tear in the annulus fibrosus, and the nucleus pulposus starts penetrating and compressing the exiting nerve root. Here you can see the dorsal root ganglion also. So when the surgeon is going to put in the scope here, the anesthesia implications are that if the patient is under local anesthesia, the analgesia with just LA is not sufficient. The handling of this may also result in bradycardia to the patient. And that's why one has to be very vigilant as an anesthetist if we are doing a case of PLD under local anesthesia. Even if in cases of central disc herniations, where now the compression will be on the traversing nerve root, and here also the patient will perceive pain. The contraindications, there are certain contraindications. Definitely not all patients will be exposed to PLD, and the surgeon may not get the results in some cases, as in spinal instability. If the patient is having severe scoliosis more than 40 degrees, if there is severe foraminal stenosis or extreme disc migration, as you may see in this here, there might be, because these are osteophytes which are compressing the exiting nerve root. So in such cases, the surgeon may use a burr, but how the results are, that is also a big question. And here, when the disc is getting migrated way beyond, so there are chances that while removing the disc, some disc fragments may remain in the canal, and the patient may still perceive pain post-operatively. So when such prolapsed disc is very common symptom, a very common complaint of so many patients, and the surgery is being offered, the anesthetist definitely come into picture now. So when the surgery is planned, there are different modalities of anesthesia what can be given. So the conventional method is general anesthesia. But here in case of PLD, general anesthesia and subarachnoid block are definitely to be avoided. So there is a reason for that. So PLD is a procedure where on table, the surgeon and patient's interaction is needed. Assessment of nerve root injury or irritation has to be assessed by the surgeon on table. And that's why the patient, if he is being given general anesthesia, that cannot be ruled out. A nerve injury cannot be ruled out. And that's why the surgeon prefers an awake patient. To determine the endpoint of decompression, the surgeon is doing the decompression, but where to stop that the entire disc is being removed, because ultimately it is a blind procedure. So that also, the endpoint also can be determined when the surgeon asks the patient that if his pain is getting relieved after the removing of disc, and the patient also cooperates accordingly. In case GA is given, spinal nerve function monitoring definitely has to be there. But in a place like Amravati, in a private setup, again, this becomes a big question. And patient cannot timely respond to the operator if the nerve is touched by mistake. And so this carries a potential risk of nerve injury, because it's a very small space. One has to remove the disc also from there. There is the exiting nerve root. There is the transverse nerve root. So all these important structures are there, which may again irritate which may inflict pain again to the patient. And that's why it is important that the patient remains responding and awake during the entire procedure. So the cardinal rule for PLD is the patient must always be in an arousable state, as the safety of neural structures is guaranteed only in an awake patient. And one has to, as an anesthetist, it is important to target the VAS score to 3 or less than 3, because it has to be only a mild pain, which can be very well tackled with anxiolytics and mild painkillers. So the need for analgesia is right from the beginning, right from the patient, the surgeon putting and piercing in the needles, then the dilators, and then the scope. So pure pain can be because of shearing of ligamentum flavum. It can be because of manipulating of annulus fibrosis, irritation of spinal nerve root, irritation of sinovertebral root. All these may cause pain, and only local anesthesia might not suffice a cooperative patient in such procedures. So it is definitely a time to rethink about local anesthesia, because analgesia is insufficient. There are definitely hemodynamic fluctuations, because there might be the blood pressure might increase, his heart rate might increase, and the patient being in prone position, there are restrictions to the anesthesiologist as well to give rescue analgesia. Because as an anesthetist, one has to prevent respiratory depression, because in case of prone position, again, airway is getting compromised. It is difficult for even to put in a Goodell's airway to maintain a patent airway in prone position. So if there can be requirement of high rescue analgesia as well. Incidences of vasovagal have also been reported. Patient's apprehension increases with pain, because the patient is very well aware that he is going to undergo a surgery for his on his spine. So that itself, the anxiety is being increased in such patient. And on the top of it, if there is a pain which is not intolerable to the patient, then he may not cooperate. Prone position itself might be very uncomfortable to the patient. So as I told you, this surgery is usually done for high-risk patients, for obese patients. So in those cases, proning itself is uncomfortable. One has to definitely rule out there is no abdominal, the abdomen is not getting compressed. All these factors come into picture. And vasovagal, the incidences of vasovagal, while the surgeon is putting in a scope through the foramen, are very high. It is because the sinovertebral nerve, which supplies the annulus and the posterior longitudinal ligament, it carries fibers of sympathetic and parasympathetic system as well. So stimulation of this nerve can result in severe bradycardia. So usually whenever the surgeon is approaching foramen, as an anesthetist, we have to be very vigilant as to at what step the surgeon is at the surgery. So many a times here what the surgeon does, after infiltrating local anesthesia before piercing with the needle at the skin, he infiltrates local anesthesia, and he will infiltrate local anesthesia with the spinal needle along the course of the scope also. And when the surgeon reaches the foramen, there also 2 to 3 ml of local anesthetics is injected. But still one cannot rule out that the patient might not have bradycardia, which is noted, and incidences do occur. And on the top of it, even the dorsal root ganglia, as I have shown you in the previous slide, the dorsal root ganglion also carries parasympathetic nerves. So both of them carry a risk of bradycardia and vasovagal. So in such cases, glycopyrrolate is must. And what I do at my setup is I usually keep 1 ml of atropine aspirated and labeled in a syringe. So there should not be any time lag if the patient is having severe bradycardia and aspirating. So that one has to keep in mind. Now, what are the challenges for anesthesiologist? Now, see, it is a very narrow space for an anesthesiologist, because the surgeon needs a quiet patient, a responding patient, an awake patient, but still free of pain. The patient has to cooperate to the surgeon, and he has to also elicit if his pain is decreased or no. So only local anesthesia is not going to provide adequate analgesia, because there are so many factors which may cause pain. So while using PIVA along with LA, again, there are chances of respiratory depression, which one must avoid. So here one has to be very vigilant that an anesthesiologist is not going to cross the maximum toxic dose of whatever anxiolytics and painkillers and opioids he or she is using. Patient may perceive headache also due to high perfusion pressure. Again, proning in case of obese patient, in case of aged patient, when this surgery is being done, the patient might not just be having a lumbar issue, he may have cervical issues also. So again, extensive neck flexion and extension cannot be given to such patients. So one has to keep in mind also many things. And again, because it is a blind procedure, the surgeon might not be sure as to exactly what time he is going to require for the decompression. It may extend to 2 hours also and 2.5 hours also. So how the anesthesiologist is going to be comfortable with such a patient in prone if the surgery is getting done only in LA and the LA is not efficient enough to calm the patient. So whenever the anesthesia is planned, one has to follow the strict protocol of surgery and anesthesia. As in case, because as an anesthesiologist, we feel, okay, the surgery is going to be under local only. But no, anytime if the plan has to be changed, so has the beforehand, all the readiness of general anesthesia has also to be there. So an anesthesia consent along with surgery consent, the patient has to be nil orally. Any spectacles or artificial dentures, ornaments has to be removed before taking the patient on table. Anesthesia for PLD involves all our routine approach, like how one is going to approach for a patient under general anesthesia. So a PAC has to be done. Any positive history has to be ruled out. The pre-op orders have to be very vigilantly followed. If a patient is hypertensive, diabetic, his sugar should be controlled. He should be taken and the antihypertensive as well. And in pre-medication, antacids, anxiolytics, what I do is I give anxiolytics in the form of midazolam 2 milligram titrated in the ward itself before taking such a patient on operative table. Even analgesics can be given and antibiotics to be given. Of course, equipment checkup of our boils apparatus and all, everything needs to be done and followed. So so it is definitely a confirmed thing that only LA is not going to work. So if LA with TIVA, we are planning here, since we have started such cases doing since only past 1 year, I have just done one case with LA with TIVA and others with epidural. I will enumerate like how I have done the cases so that the experts and all the SAMS office bearers can enlighten us if there are other ways to approach such a patient. So in prone position, oxygen and nitrous was started in the ratio of 50:50 with nasal prongs. IV fluid in the maintenance dose of 100 ml per hour. Preemptive analgesia, which I give is paracetamol 100 ml IV. And pre-medication, midazolam 2 milligram was given in the ward itself. So, and of course, glycopyrrolate. In one patient, I had given IV fentanyl 50 micrograms when the surgeon was piercing the entering the foramen. But when I had done this case, LA with TIVA, I had found that the patient was very uncomfortable and only fentanyl did not work, or it did not give a good analgesia, and definitely the patient was continuously, moving, not cooperating with the patient, with the surgeon. His heart rate, which was a baseline at around 80 before the surgery, had gone up to almost 100, 115. And then I had to add little bit of propofol, around 20 milligrams titrated doses. And even again, midazolam I had to give. So in such cases, basically, because the patient was prone, my hands were tied up because there was definitely a certain limit beyond which I could not give him rescue analgesia. So then there are literature where it is being proven that epidural also works very good in PELD. It suffices both factors, conscious cooperative patient and perfect analgesia in prone position. And there are literature also about the role of ropivacaine in such cases, because ropivacaine, being a very less potent as compared to bupivacaine, have been tried in enormous cases in case of epidural analgesia for PLD. So then the other case what I did, the other case what I did was a 74-year-old female with L4, L5 disc herniation with lumbar radiculopathy. She was posted for PLD. Her risk factors were she was a known case of diabetes, hypertension, bronchial asthma, but on regular treatment. She was also a known case of OSA and on home CPAP. An operated case of umbilical hernia in 2022 under spinal and with no post-op complications. This was her MRI, which showed a disc L4, L5 here in the lateral cut section. You might not be able to visualize the disc here because this is a central cut. Here, definitely, because the disc was laterally. The point of concern in this patient, because she was on bronchodilators, her baseline heart rate was 110 per minute. Her blood pressures were 150/90. There were no significant findings in her respiratory and cardiovascular system. She was mildly obese. MPC was grade 1, good mouth opening. Her saturation on room air was 90%. Respiratory rate was 16 per minute, but her breath holding time was very less. Apart from all other investigations, ECG was showing sinus tachycardia. Her X-ray had hiatus hernia. Her 2D echo was ejection fraction was adequate, 40%, with severe pulmonary hypertension. And PFTs were also done because she being a known case of bronchial asthma, OSA on home CPAP, it showed small airway obstruction, but there was good reversibility with bronchodilators. And the disc prolapse was at the level of L4, L5. This was the ABG on the day of surgery. Definitely her PO2 was less. But it was adequate, and since she had a single level disc, she was posted for PLD. So when the case was posted, I planned the anesthesia to be done under caudal epidural. Now, caudal epidural, as we all know, with the conventional technique I palpated the sacral cornu bilaterally and under all aseptic measures, infiltrated the area with local anesthesia using 2% lignocaine with adrenaline. Then, by using a 16 gauge epidural needle, I entered the sacral hiatus, and this is the picture which coincides anatomically with this picture what you see on the lateral side. This is the AP view with the needle introducing in the sacral hiatus. Many a times nowadays, even fluoroscopic guided caudal also is given, but since we are well versed with landmark techniques, so that was not a issue. And fluoroscopy guided because ortho OT definitely provides you with CR. After that injection, the radio opaque dye was put in, and it was very well seen on the fluoroscopy. The epidural catheter which was inserted, it was fixed at the mark of 15 centimeters. So as to ensure that the segments what needs to be blocked, the catheter reaches there. This is how the epidural catheter was fixed. And because the previous surgery, which was done under only LA and TIVA, I didn't have a very good experience. So epidural catheter was fixed because even more rescue analgesia and top-ups through epidural catheter can be given. The epidural catheter was fixed at 15 centimeter. Drug what was given was 4 ml of 0.75% ropivacaine with 6 ml of 0.2% ropivacaine. Definitely because the main goal was to have only sensory block and not motor block. The aim was to achieve only sensory block. Rescue analgesia in this patient, I had to give around dexmedetomidine 30 microgram along with midazolam 2 milligram in titrated doses. That is over a period of 2 hours. Another patient was done for PLD. What she was posted for PELD was a known case of Devick's disease. She was a 34-year-old female and on steroids and monoclonal antibodies, rituximab. She had complaints of radiating pain over left lower limb, and her MRI studies showed a disc prolapse at L3, L4 level. I don't have the documents of this patient, but this was the case scenario. So in this case, because the level was L3, L4, we the previous case when caudal epidural was given, still that patient required rescue analgesia. So another modality what we thought, and it is there in my references also, that even lumbar single shot epidural definitely can be given in such patients. So I thought of giving a single shot lumbar epidural at the level of 1 second. My battery is turning. 1 second. I will have to switch on the battery. Yes. Am I audible?
Yes, you are audible.
Yes.
Yes, Radha
Yes.
madam, you are audible.
Yes. In this case, we gave under all aseptic measures, we gave a single shot lumbar epidural at L2, L3 space. And the drug given was 10 ml of 0.2% ropivacaine. No rescue analgesia was required. The relief of pain was elicited on table immediately after the decompression. So when basically I didn't have a good experience of the case which was done in LA with Tiva. And now the other two cases, what was done was, one was with caudal epidural. Still the patient required rescue analgesia. So we tried for the next patient, single shot lumbar epidural. So in case where we tried a single shot lumbar epidural, 10 ml of 0.2% ropivacaine was given. And this patient was absolutely cooperative, pain-free. She did not even require hardly 1 milligram of midazolam was required. I think Rohit was also there with us when we were doing this case. And this was done very nicely. So, that's it, how we have done here. There are other complications of PLD which are known are dural tear, retained disc fragments, hemorrhage may also occur, and if it at all it is there in very less intensity, then the surgeon will control it with continuous infusions of normal saline. Or else 1 ampule of adrenaline can be put in a 3 liters of normal saline, and that wash can also be given. But if it is still persistent, one has, as an anesthesiologist, one has to keep in mind that 2 sterile mops should be there on the surgeon's table, so as the patient may anytime be converted into GA. So just put 2 sterile mops. The stretcher has to be there outside the operation theater. Immediately turn him supine, put in a GA, and then explore, because that chance you cannot just say that it won't occur. There is a possibility. So then intraoperative irritation of the exiting nerve root, that may also occur. Patient may desaturate in prone position. That is the biggest challenge for an anesthesiologist, because the surgeon will insist to do these cases in local only. But if the patient is not cooperative, so as an anesthesiologist, as a head end, how are you going to manage the airway of a patient who is in prone? Because there are very limited things which you can do in that position. These are all my references. Thank you for the opportunity given.
Dr. Ashish Bhattad, please, if you have any questions, come up. Dr. Ashish.
Yeah. Fantastic presentation from Radha madam, and hats off to her eagerness to learn the orthopedic procedure and then her trials of the anesthetic procedures. Everyone must have got the hint that she belongs to the orthopedic husband. The question is from her only, that if such patients comes to any of the experts here, how will they manage this? Because it's a big challenge. And any in other setups, any anesthetist will like to run away from such case. Dr. Cham? Dr. Cham sir is there? Ivan sir?
That was a very extensive presentations, and I really loved the way she had taken it from how it was earlier and what was the procedure now that she's following. Of course, there would be some questions regarding the most sought after segmental spinal, which is the practice nowadays by most of the anesthetists. We don't do that, though we have 4 spine units, and we do at least 10 to 12 spine surgeries per day. They have started doing endoscopic spines as well. And in last 2 months, they must have done almost more than 250 endoscopic spine surgeries. They take not more than 1.5 hours, but most of them are instrumentation. They do endoscopic instrumentation as well. And they do endoscopic decompression. So we don't do just the disc removal. They do a lot of these procedures, and they do it for listhesis and some deformities as well. So honestly speaking, I don't have any experience regarding this role of local anesthetics in spine surgeries. Of course, in the past, when I was in my old place, Miraj, the surgeon himself, they used to do these procedures under local. The only thing that I used to do was intravenous dexmedetomidine, a continuous infusion with a bolus prior, which used to keep the patient quiet and calm. That was the only thing that I used in the past, along with midazolam, of course. There are certain of my colleagues who do this. Vinayak Patel, I think he was here on this bench, and he used to do it under spinal. Then I think some in Nagar, Subhash Tuvar was practicing that. He also had presented in our prac. Naresh, of course, he does a lot of this. He must have presented a couple of times. But I appreciate one of my colleagues from North. She's from UP, Richa Chandrashu, who does a lot of these under double spinal technique, and she does instrumentations as well as she does decoms, and she gives at a very high level, and she uses hypobaric and hyperbaric, a combination of these local anesthetics at 2 levels. And she really sends all the videos to me, and I found it quite entertaining in fact that the lower limb is absolutely unparalyzed with this particular technique, and the surgeon can understand the neuromonitoring from that. Of course, that's not a complete neuromonitoring, but as madam suggested, yes, at such centers, of course, you need to progress from what you have done and then slowly build up your techniques upon that. And I really appreciate what she has done in this context. So this is what I have to say.
Thanks, sir, for your kind words.
Thank you. Thank you very much, sir.
Question from my side. The aim of doing this such type of procedure under local is that we should know about any injury to the nerve or something like that. But giving epidural or something like hyperbaric or isobaric 2-level spinal something, this will not give any idea about that. So you are hampering that type of aim of local is not going to aim of purpose of local is to have a sensation from the patient side, and giving epidural and spinal will not serve that purpose. It's a
Ma'am, you're
simple like
asking
you
to
can
me.
give GA also such type of patient.
Ma'am, you're asking to me or the author or the faculty.
Faculty just I am asking because she said in a initial slides that the aim of doing such procedure under local is that the surgeon should know whether he has injured the nerve or something like that. But giving epidural or spinal or something like that will not serve such purpose.
Sir, that's what I read the literature also, and used just 0.2% of ropivacaine, because it was definitely the patient was able to move the limbs. Everything was like he was able to respond to the surgeon also. But when I did the case under only local anesthesia and TIVA, I was not comfortable because the patient was continuously wincing.
Exactly. I'm not. A purpose of local anesthesia, what I'm going say is to know about the any whether you have solved the problem after removing the disc. That will not solve with this TIVA or spinal or epidural. Even with the less concentration of the drug, even the patient is
Even
moving
with the
his way.
0.2% ropivacaine,
Yeah,
because ropivacaine is very less potent, but still you
And
feel that it won't solve the purpose.
if you are given local to that part, You have anesthetized that part. Simply.
Okay. Okay, I got
So
it.
that will not solve the purpose. Either you have to do under local or you can give anything.
But
That's
then
my,
that's
my
what is the
opinion.
correct modality to because
Or
then
you have to monitor. After giving this block, you have to monitor.
okay.
Neuro monitor
The,
about the
the only way that you can monitor would be somatosensory evoked potentials.
exactly.
That is what we routinely do for all the deformity corrections. And as Cham said, injecting local at that particular site, because you will be anesthetizing the sensory motor as well as the dorsal root ganglion and the sympathetic. So it can be a differential block as well, because there are a couple of fibers which are present and which will be blocked at different concentrations. So it is not necessary that the motor and sensory would be blocked at the same concentrations in one particular patient. But in other patient, it might block both the components. So we are really not sure about which drug, I mean, which concentration would block which component of that particular nerve fiber. It also depends upon the concentration gradient. It also depends upon the washout time, because most of the things will be washed out the moment they start endoscopic surgeries. So that is the scenario. Like, so in our institute, we usually do it under general anesthesia, and I have even stopped giving the erectospinal plane blocks, because there is a lot of controversy regarding erectospinal plane blocks in spine surgeries. So we don't do that. At least I don't do that now. I ask the surgeons just to infiltrate paraspinal injections of local anesthetic, and that would be more than enough.
So for endoscopies also general anesthesia is given, sir?
Yeah, at least in my institute, we give general anesthesia. I think Dr. Naresh is here. He has
Yes,
raised his
Dr.
hand.
Paliwal, sir, I also have seen. He
wants to add to something. And you go to Naresh, sir.
Hello. Good
Yes,
evening,
sir.
everyone.
Very good evening, sir.
Actually, with very low concentration of drug, like hypobaric drugs, we are doing it routinely now. Only the sensory part is blocked, sensory and sympathetic, and the motor one is spared. So you can always test for the integrity of the roots with a very low concentration of drug. What we call nowadays is a posterior spinal hemianesthesia. When we give hypobaric drugs in a prone position, I think after this lecture, Dr. Meenal will be presenting on this.
Yes.
Posterior spinal hemianesthesia. She will be presenting also the videos. So it's not the motor roots are blocked with such a low concentration. The another thing which I wanted to ask Dr. Radha is, can you feed the catheter from caudal area in adults?
That's what it has been there
Actually,
in one
it
of
is
the
only in children below
literature,
6 years
and
where the loose
I
fat.
later on basically the catheter was in situ. The dye was seen very nicely covering the area, but since the patient required rescue analgesia a lot, definitely, because the patient was having little bit of osteophytes also over there, it could not be negotiated, and that is the reason why the patient was still uncomfortable even after giving rescue analgesia. That's what I realized later. So in the next case, I changed my plan, that rather than giving caudal epidural, I thought of giving single shot lumbar epidural. Sir, I think you are mute. Paliwal, sir.
Hello. Let Meenal finish our lecture so that you can see the videos what we have done in posterior spinal hemianesthesia with hypobaric drugs.
Yes.
And the other thing which I wanted to say is about Dexket. Dexket is a very good sedation for such cases. I mean, they don't hamper your airway tone and integrity, and combination of dexmedetomidine and ketamine. Somebody asked the question whether we can do it under Dexket. It's a very good agent. So thank you very much.
Thanks. We are running short of time. We will move to the next lecture. Rohit Ganesha, sir, please handing over to you.
Yes. Now, because of shortage of time, we cut down these things. I'd like to call upon Dr. Meenal Kokate, Madam, for the next lecture. She has done her MBBS from JNMC Wardha and DA from St. GS Medical College and KM Hospital Mumbai and DNB from KM Pune. Presently, she is working as an assistant professor at Dr. Panjabrao Medical College, Amravati. She was an ex-associate at Wockhardt Hospital, Mumbai. Her area of special interest are awake blind nasal intubation, segmental spinal anesthesia, landmark guided LOR, and USG guided blocks. She also has few national as well as international publications to her credit. I call upon Dr. Minal Kokate, madam, please.
Yes,
Minal,
sir.
madam?
Thank you, sir. Yes, sir. Thank
Okay.
you, sir. I'm starting my screen sharing.
Yes, go ahead.
Yes. Yes, sir. Is it visible?
Yes, it's visible.
Yes.
Yes. Okay. Good evening, all. I'm going to talk on the topic of intrathecal hypobaric drug, how and where I use it. So, as the topic is discussed by Radha Madam on the endoscopic lumbar discectomy, she has mentioned that one of the modality for these type of surgeries is also use of hypobaric drug. So, other domain where we can use the hypobaric drug is the plastic surgeries like tendon sorry. Yes, I'm
My
audible.
battery is dying.
Am I audible?
Yeah, you're
You are
audible.
audible.
Continue.
Yes, yes.
Yes,
Yes.
you
So
are
the
audible.
other domain is the plastic surgery domain, where the tendon transfer surgeries or any surgeries related to tendon, the surgeon needs to spare the motor block and at the same time needs the sensory block. So first of all, what is the slide about the baricity of the local anesthetic? So there are three types of baricities like isobaric, hypobaric, and hyperbaric drug. So what we use regularly is the hyperbaric drug, which is for the for achieving the unilateral spinal anesthesia, we use hyperbaric drug. But at the same time, if we want to use unilateral spinal anesthesia, that can also be achieved with the hypobaric drugs. And the isobaric drug, we all know there is no effect of gravity when we use isobaric drug intrathecally, because the mean density of the CSF at 37 degrees Celsius is 1.0003, which varies from 1 to 1.0006. So it has the same density as that of the CSF. So isobaric drug will stay where intrathecally where we put it. But the hypobaric drug is has the density or specific gravity less than that of the CSF, so it will float up. That is because it is lighter than CSF. So it will be settled. The drug hypobaric drug will settle down the area against the gravity. Then the hyperbaric drug, as we all know, it is heavier than CSF. Now about the hypobaric spinal anesthesia, it provides the selective intrathecal spread of the local anesthetic on the non-dependent side with hemodynamic stability and attempting to restrict the extent of somatosympathetic paralysis to the operative site only. So the hypobaric spinal anesthesia has two different modalities. Like it can be, it achieves unilateral spinal hemianesthesia and posterior spinal hemianesthesia. Unilateral spinal anesthesia, we know that just the operative site will get blocked. What we know about the hemianesthesia is sensory part will get blocked and there will be motor sparing. Now, why this happens with the hypobaric drug? Because the distance between the spinal roots on the right and the left sides and anteroposterior is approximately 10 to 15 mm, which is responsible for the this kind of unilateral spinal hemi and posterior spinal hemi anesthesia, and also the achieving sensory block predominating over motor. So, what are the different factors for this selective block? Density of the local anesthetic, which I have already discussed. Then the speed of injection. When we give the hypobaric drug with a particular speed of around 0.1 ml per second, then there will be a slow flow or slow mixing of that hypobaric drug with the CSF. If we give fast injection, then because of the turbulent flow into the CSF, the expected part will not expected levels will not be achieved, because because of the turbulence in the turbulence of the drug with the CSF. Then whenever we want to achieve the unilateral anesthesia, either with hyperbaric or hypobaric, we have to keep the patient in that position for at least 15 to 20 minutes for the drug to get settled down. Then the other things are dose, concentration, and the volume of the local anesthetic use. With hypobaric drug, if we want to achieve, if we are achieving the sensory block and rather than the motor, so we have to go very low on the concentration as well as on the dose. Then the last thing is the type of the needle. So literature says the pencil point dura splitting needles, they are more favorable for achieving the hemianesthesia with the hypobaric drugs rather than the Twinkies. Now, what are the advantages? As we are very low on the concentration with the hypobaric drug, there is hemodynamic stability is achieved as compared to the hyperbaric drug. Also, we can target the specific operative area. There will be restricted spread. Then, as the drug is blocking the sensory routes mainly, so there will be excellent analgesia. And for example, for bipolar surgeries, orthopedic surgeries, which has to be done in the lateral position with the operative side up. So directly in that position only, operative position only, we can give the spinal anesthesia with the hypobaric drug, as we need the non-dependent, as the operative area will be non-dependent, and hypobaric drug will get settled down on the non-dependent area. So afterward, there is no need to change the position. And the important thing is the patient satisfaction, because patient will have the sensory anesthesia, but motor sparing is there. So the discomfort with the paralyzed leg will not be there. So that is definitely psychological impact on the patient. But at the same time, talking about the pitfalls of the hypobaric drug, there is unavailability or scarcity of the hypobaric local anesthesia solutions. It has to be prepared at the bedside before each spinal anesthesia by mixing the isobaric solutions with sterile distilled water with undue utmost precautions needed regarding the sterility. It is impossible to measure the density of this preparation at bedside. However, even small change in density can influence the spread of local anesthetic. Also, there can be unintentional rise in the block height because of the accidental alterations in the baricity. And the last thing is the time constraint. Whatever cases we have performed, they are expected to get over in 1.5 hours. So if the long cases we have to do with hypobaric, that is need to be studied. So time constraint is there. Now, I have added some literature. So here about the hypobaric drugs. Here there is a study, comparative study of constant dose of intrathecal hypobaric levobupropion with varying baricities in the lower limb surgeries. So here the author wanted to know the how much should be the baricity. They use the hypobaric drugs only here. Isobaric levobupropion mixed with the distilled water. The quantity of distilled water they took was different in the 3 groups. That changes the baricities. So they just wanted to know, to achieve the better block characteristic, what baricity they need. So this is one of the study. Then in the other study, there is the author showed the unexplored role of hypobaric spinal anesthesia in cardiac patient with low ejection fraction. He did a case series, and he concluded that the practice of hypobaric spinal anesthesia can be considered as one of the options in the anesthesia management of infraumbilical superficial surgeries of moderate duration in high-risk cardiac patient with low EF. So there are many surgeries which have concluded that the hypobaric drugs have the hemodynamic stability and with a good, safe and effective profile. So this is one of the article which I have got that elaborated thoroughly about the unilateral and posterior spinal hemianesthesia. Now, going on the cases, all the patients were undergone the pre-anesthesia checkup. Written informed consent in the local language from the patient and relatives was taken. All the backup plans and general anesthesia preparation kept ready. And also we have done the post-operative follow-up. So this was the first case. Here the 50-year male with high-risk uncontrolled diabetic COPD post-PTCA posted for gluteal abscess IND in prone position. Here the spinal anesthesia was given in the prone position with the 10 to 15 degree head low at lumbar L3, L4 level with the hypobaric levobupropion 0.15%, 3 cc volume. Here the additive was not added because the procedure was expected to get over. It was an IND procedure, so it was expected to get over within 30 minutes. Here the hypobaric solution was prepared with 1.5 cc of preservative-free isobaric levobupropion and with extreme sterility, 3.5 cc of sterile distilled water was added into it. So total 5 cc volume, out of which 3 cc drug was given. So in milligram, it was 4.5 milligram. In 5 to 8 minutes, sensory level below T10 was achieved with a minimal motor block, and procedure went on for around 30 minutes with absolutely stable hemodynamics. So I will show the video. Here the spinal was given in the prone position at the L3, L4 level, and the 3 cc of the hypobaric drug was injected. The targeted area is the gluteal region, so 10 to 15 degree of head low was given because we want to keep targeted area against the gravity. Now the second case. So he is the 68-year male with diabetic hypertension with medical renal disease. He is a neglected, debilitated patient with multiple carbuncles over the left side of upper back and axilla, posted for the excision and debridement. Here, the spinal anesthesia was given with the operative side up, that is left side up. So right lateral position with 10 degree head up position. Here the spinal was given at the T10-11 thoracic spinal paramedian approach. Again, the drug used was hypobaric injection levoanavin 0.15%, and here the additive 20 microgram fentanyl was added because the procedure was thought to be taken 1 hour time at least. Here also the hypobaric solution was prepared with 1.5 cc, that is 7.5 milligram of preservative-free isobaric levobupropion. 3.5 cc of sterile distilled water was added into it to make the total volume of 5 cc, out of which 3 cc drug was given. In around 5 to 8 minutes, level up to T1 to T2, including the axillary area on the left side, was achieved. Initially, as the patient was extremely high risk, so initially there was a fall in BP, which is managed with injection termini 6 milligram. Surgical duration of around 1 hour, which was uneventful. So here we can see the area, including the axilla and the upper back on the operative side, left side. So there was a proper sensory anesthesia on that side, left side, as compared to right. And patient was pain-free. The third case, here the 50-year male diabetic hypertensive. So he was posted for L4, L5 endoscopic discectomy, single level. Here the spinal anesthesia was given at L2, L3 level in prone position with 10 to 15 degree head low, because again the targeted area is lumbar area here. So we keep the 10 to 15 degree head low position so that the CSF will go towards gravity and the hypobaric drug will remain or cover the targeted lumbar area. With spinal was given with hypobaric levobupropion, again 0.15% plus 20 microgram of fentanyl. Within 5 to 7 minutes, T12 below, posterior sensory spinal hemianesthesia with minimal motor block was achieved. So here, as we know, the anterior roots in the spinal canal are motor and the posterior roots are the sensory. So when we use hypobaric drug in the prone position, so the hypobaric drug will block the sensory nerves more than that of the motor. I will play the video. So this was the L4, L5 endoscopic discectomy. Spinal was given as L2, L3 position level, sorry. And the 10 to 15 degree head low was given to achieve the targeted area. The vitals were absolutely stable. and patient was pain-free, doesn't needed the any kind of sedation, and shifted himself at the end of surgery because the motor sparing was there. So to conclude, low-dose hypobaric spinal has an excellent hemodynamic stability compared to that of the conventional hyperbaric drugs. Preferential redistribution of the block to operative side could be the main reason. This entity requires further research, as by avoiding unnecessary motor block of the non-operated side, we can improve the hemodynamics, decrease the chances of venous thrombosis, and can prompt early ambulation. So it is a simple, safe, economical, and efficient use of the hypobaric drug in spinal gives satisfactory outcome with respiratory cardiovascular stability, particularly in the high-risk patients. The high-risk patient posted for thoracic, spine, anorectal, lower limb surgeries where GA is risky. This technique gives hemodynamic stability with differential block, that is sensory more than motor, leading early recovery. But still, further clinical trials and RCTs are needed to be done in this field because hypobaric spinal has a definitive potential to enter into the clinical arena. Thank you. Thank you for giving me opportunity.
Thanks, Minal. A wonderful talk. And nicely presented with the references. And you introduced a new, you talked about a new technique into the field of anesthesia. We are proud to that the person who is beyond is mentor in this hypobaric anesthesia belongs to our city, Dr. Paliwal sir.
Yes.
Yeah. Now we have the easy approach to the Paliwal sir, and we are always in touch with him regarding all the questions about this. One question I will like to ask to Dr. Diwan sir. Sir, in our residency, Diwan sir is there?
Oh, yes, I'm here.
Yes,
Is
he
there?
is.
Sorry?
Yeah, I'm here. I'm here.
Yeah. Sir, in our residency, we have been taught that while performing subarachnoid block, the needle should be inserted preferably below the level of the conus medullaris, so that trauma should not happen. In all the books have been mentioned. But in this technique, we are giving it a higher level. Okay. I just want to know your perspective regarding the medico-legal point.
Now, considering the medico-legal point, there are now a lot of anatomical dissections, anatomical factors which have been included, particularly in the thoracic area. There's a wonderful chapter written by Andrew Van Zundert. He's a very close friend of mine. He has written about the thoracic. But I agree on one point that defending in the court would be a problem because the earlier authors have mentioned that never go beyond the beyond the L4, L5. But now people are venturing at very high thoracic levels. Even I did it in the past, but I used to use a combined spinal epidural needle. I used to see that my needle is in the epidural space, and then I used to advance my spinal needle through the CSC needle. But this was for laparoscopic cholecystectomy in the past. This was almost, I'm speaking about 15 years back, when they used to do a lap chole in my place. But then I eventually gave that technique up. I don't know why. Slowly I moved away from it, and the surgeon preferred more of general. But I think Dr. Naresh and his colleagues and all, they have what you can say, they have mastered this technique over a period of time. And I think you should be mentored be mentored with such kind of faculties. Only then you can go ahead with this sort of technique. You should see how they are being done, to the extent that now they have been taking master classes. In the recent AORA also in Pune, they did a master class. So over a period of time, the levels have changed. From alpha S1, they are going to the thoracic level. At one point of time, I used to give it a level of T2, T3 for very high spine surgeries. But then the patient became apneic and the surgeon was pissed off. So I thought of not going for this particular technique. But I think the things keep on changing, and if anybody really wants to do that, they have to be mentored. Just like very, very nice and beautiful presentation by the one who had presented this Dr. Meenal. I should congratulate her on this occasion.
Thank you, sir. One more question, sir. In one of the articles published in 2002 in the journal CNS Drugs, it has been mentioned that the levobupivacaine and ropivacaine is not approved by US FDA for the intrathecal use. Just want to inquire about the recent updates on this. And also, I want to know that other than US FDA, there are any other authorities which give the permissions which are valid?
I am really unaware of this, and I'm not sure about any other authorities who would allow these drugs to be used in clinical scenario. But I remember one sentence, and I always quote: the epidural space and the intrathecal space is always considered as a human dustbin. So whenever you have a new drug in market, you just take it off the shelf and put it in the epidural space just to see its clinical significance. I think you should be very, very much aware of all these things. You should look into the do's and don'ts about using all these newer kind of drugs. The epidural space, remember one thing, is devoid of reticuloendothelial cells, and it's very easily accessible to inflammation and infection. Any new drug in the epidural space or in the intrathecal space is going to cause some or the other sort of inflammation. You might trigger that, and the patient might land up in some or the other sort of trouble. So just to be careful from my point of view. That's what I would say.
Thank you, sir. Thanks a lot for it. Now we will move out to the next speaker, Dr. Anup. He missed because of some power failure. Anup, are you there?
Yes, sir.
Can you continue with the presentation?
Yes, sir. Yes, sir.
Yeah, thank you.
Anup, start.
Okay. Thank you, sir. Is my presentation is able to see, sir?
Yes, now you are ready.
Thank
Start
you.
off with the slideshow.
Okay. Extremely sorry, sir, for the discomfort. So our today's topic is landmark guided blocks. So its outline is introduction, brachial plexus blocks and its types, technique, wrist block, complication and references. So we will start with brachial plexus anatomy. Brachial plexus is an arrangement of nerve fiber running from spine forward by the ventral rim of the lower cervical and upper thoracic nerve roots. It includes from above the fifth cervical vertebra to underneath the first thoracic vertebra, that is C5 to T1. It proceeds through the neck, the axilla, and into the arm. The brachial plexus is responsible for cutaneous and muscular innervation of the entire upper limb. The tongue passes laterally and lies around the subclavian artery while passing over the first rib to enter the axilla between the clavicle and scapula. Behind the clavicle, each trunk splits into anterior and posterior division. These recombine to form the posterior, lateral, and medial cords around the axillary artery. The upper root, that is C5 to C7, tends to stay lateral. The lower one, that is C8 to T1, tends to stay medial, and all roots contribute the posterior cord, which gives the radial nerve. Here is a diagram of brachial plexus showing C5 to T1 roots. There is trunks, division, and cords, and the cords having their respective branches. So brachial plexus blocks have different approaches. The choosing depending upon the site of the proposed surgery, we will choose the approaches, that is interscalene, supraclavicular, infraclavicular, and axillary approach. So interscalene used for shoulder, upper arm, and elbow surgeries. Supraclavicular approach is for elbow, forearm, and hand. And axillary is for forearm, wrist, and hand. Interscalene block. It developed as an alternative to supraclavicular approach to brachial sheath block. Advantages, as it can be used when proximal block is required for shoulder surgeries, can be performed for arm surgeries, and it reduces the risk of pneumothorax. Landmarks are usually very clear in also stout patients comparatively in other obese patients. And a disadvantage regarding interscalene blocks, like essential to elicit paresthesia, which is most important part. If it is not elicited, then there is a chances to get failure of that block. Supplementary ulnar block may be required. Common and serious side effects like sparing of the lowest branch of C8 and T1, which innervate the ulnar forearm. So its indication in shoulder, humerus, and forearm surgeries. So here is a case of 45-year-old male, which I have did in last week, having hypertension, diabetes, having a fracture of humerus, surgical neck fracture. For that, I have given an interscalene block to him. Here is a picture of that patient showing the interscalene sternocleidomastoid muscles of to clavicular head and anterior head. Along with that, here is a cross mark, which is a needle entry point of entry where we can insert the needle. Here is a dotted line which is showing an external jugular vein, and here is a clavicle which I have drawn. These are the landmarks from where we are entering the needle. So positioning of the patient. So asking the patient to turn from the side to be the block. The posterior border of the sternocleidomastoid is palpated by having the patient briefly, asking the patient to lift his head. Then interscalene groove can be palpated by rolling an index finger posterolaterally from the border over the belly of the interscalene muscle into the groove. A line extending laterally from the cricoid cartilage and intersecting the interscalene groove indicates the level of transfer process of C6. In the previous diagram, we had already seen here the dotted line, which is showing a 4-part cross mark, that is a C6 transfer process, and from that we are inserting a needle. A line extended laterally from the cricoid cartilage and intersecting the interscalene groove indicate the level of transverse force of C6, and EJV often overlies that point of intersection. So we can just lateralize that point by 1 to 2 mm. So techniques of the interscalene block, there are Vinny's technique, Myers approach. As the block is developed by Dr. Vinny's, so for that the landmarks are the cricoid cartilage, that is C6 transfer process, posterior border of the sternocleidomastoid, and interscalene groove, which we are palpating with the help of index finger. The depth of insertion of the needle should be 1 to 2 centimeter, which is very near to the surface of the skin. Then Myers approach, which is another approach for giving interscalene block. Landmarks are the posterior border of sternocleidomastoid, thyroid cartilage, which is a C4 prominence, that is C4 transverse process, then subclavian artery just above the clavicle. For that, we are selecting the point that is middle part of the clavicle. Procedure in Myers approach, that mark the posterior border of the sternocleidomastoid at the level of thyroid prominence.
Time.
Yes, sir. C4 level. Then palpating the subclavian artery behind the clavicle. Line joining reduces these 2 marks, approximate the groove, and direction of the needle should be caudally, passing along the axis of the interscalene groove towards the subclavian artery. Indications of that block is for shoulder and humerus surgery, difficult anatomy, having patient like short neck resulting in poor identification of the groove. So we can also, in that cases, we have to ask the patient just to blow off the air from his cheek, so that the anatomical landmarks will get little bit more visible. With the help of EJV, we can locate other landmarks. And depth of, in case of we have to prolong that anesthesia, we can use a continuous catheter technique also. So from that, by using a Tohis needle, we can introduce a catheter for long-standing surgeries. So for that, depth of insertion will be at 3.5 to 5 centimeters. And advantages for that insertion of the catheter is like that to, especially for shoulder arthroscopy, we can give anesthesia with the technique. Complication in the interscalene block is ipsilateral diaphragmatic paralysis, severe hypotension and bradycardia, that is basal Jerich reflex, inadvertent epidural and spinal block, nerve damage or neuritis, intravascular injection with seizure activity, Horner syndrome, which is the most common, which I used to encounter with that, dyspnea and hoarseness of the voice, puncture of the pleura may cause pneumothorax, hemothorax, hematoma, and infection. C6 neuropathy suggests intraneural injections. Another next block is supraclavicular block. So surgical procedure on the elbow, forearm, and hand, we are used to give that supraclavicular block. Blockade occur at the distal trunk proximal division level. Here is a diagram showing again the 2 leaflets of the sternocleidomastoid, that is tunnel head and clavicular head. Here there is a clavicle, and another the cross mark showing the needle point for the insertion of the needle, which is just above the clavicle and just lateral to the subclavian artery, which we are palpating in that block. So location of the supraclavicular block. 3 cords of the brachial plexus are clustered vertically over the first rib, that is cephaloposterior to the subclavian artery. The neurovascular bundle lies inferior to the clavicle at about its midpoint. So technique for that block, we just give a supine position to the patient, head turn away from the side to be blocked. The arm of the anesthetized is adducted and the hand should be extended along the side towards the ipsilateral knee as far as possible. In that classic technique, we need to identify the landmarks. The posterior border of the sternocleidomastoid is spread, palpating the finger that can roll over the belly of the anterior scalene muscle into the interscalene groove, where a mark should be made approximately 1.5 to 2 cm posterior to the midpoint of the clavicle. Palpation of the subclavian artery at that site confirms the landmark, which is the most important landmark. We can easily palpate the subclavian artery. After appropriate preparation of the skin and development of skin wheel, the anesthesiologist stand at the site of the patient facing the patient's head. A 22 gauge 4 cm needle in a caudal, slightly medial and posterior direction until a paresthesia is elicited or the first rib is encountered. If a syringe is attached, this orientation causes the needle shaft and syringe to lie almost parallel to a line joining the skin entry site and the patient's ear. If the first rib is encountered without eliciting a paresthesia, the needle can be systematically walked anteriorly and posteriorly along the rib until the plexus is located by doing little manipulation of the needle. Location of the artery provide a useful landmark. The needle can be withdrawn and reinserted in a more posterolateral direction, which generally results in paresthesia, that is tingling sensation, by asking patient that he or she is getting any tingling sensation in his or her hand or elbow. Or motor response in the hand or elbow or fingers we can elicit. Another technique is a Patrick technique. If no paresthesia are elicited, but the rib is contacted with the needle or hit by the needle, redirected it posterolaterally, and a local anesthetic solution is injected between the rib and behind the artery, that will helpful in obese patient. It will not give completely sure shot idea that supraclavicular block will give 100%, but it will give a good analgesia. If subclavian artery pulsation and landmarks are not fed, the point where the straight line portion of the EJV in the previous image, which I have shown the pointed dotted line, which is remarkable an external jugular vein. So the straight portion of the EJV crosses the clavicular. Just use and identify the mid-clavicular point. Asking the patient to blow out his or cheeks 3 to 4 times, it will make the EJV more prominent. It will helpful especially in obese patient or the patient obese along with a short neck, where the anatomical landmarks are difficult to locate it. So in that case, we will ask patient to blow his or cheeks for 3 to 4 times so that the EJV will make prominent. And the needle is inserted 1 to 2 centimeter behind the clavicle and elicit the paresthesia for the motor response in his hand. Here is the diagram. Again, the 60-year-old male patient, 65-year-old male patient for the distal radius and ulnar fracture. For that, I have given the supraclavicular block. Here, the two bellies of the sternocleidomastoid. Here is the cricoid notch, the line which is showing a C6 transfer process. Another, the dotted line representing a EJV. The dot, a big dot, is showing a subclavian artery, and just lateral to it there is a cross mark, which is a point of insertion. Here is the cross mark, which is showing a needle point of insertion. So complications for the supraclavicular block, it is pneumothorax, phrenic nerve block, Horner syndrome, neuropathy, and landmark for that I already told, that is the midpoint of the clavicle and subclavian artery pulsation. Another block, that is axillary approach. Indications for the axillary approach is it includes the surgery for the forearm and hand. Elbow procedures are also successfully performed with the axillary approach, but sometimes it may not be. Blockade occurs at the level of the terminal nerves. Blockade of the musculocutaneous nerve is not always produced with this approach. That is the drawback of the axillary approach. Here is a schematic diagram along with the landmarks. With the red color, that is axillary artery. Along with that, there is a dotted line bicipital sulcus. There is a anterior axillary fold, pectoralis major and pectoralis axillary fold. So landmark in that axillary approach is the axillary artery, the most important landmark, which we have to first palpate with the thumb. As in right-handed person, with the we will palpate with the left hand thumb to the axillary artery. The nerve maintain a predictable orientation towards to the artery. The median nerve is found superior to the artery, the ulnar nerve is inferior to the artery, and the radial nerve is posterior or somewhat lateral to the artery. That is the structure of the nerves which is lying around the axillary artery. So at this level, the musculocutaneous nerve is already left the sheath and lies in the stance of the coracobrachialis muscle. So axillary artery palpation with the thumb of the left hand in the right-handed person. So technique of the axillary approach, the patient should be in the supine position with the arm to be blocked, and the arm of the patient is placed at the right angle to the body and elbow is flexed to 90 degree. And as the patient, am I audible? Am I audible, ma'am?
Yes, yes, Alok, go ahead. Continue.
Okay. A transarterial technique can be used where the needle pierces the artery through and through and go ahead. So 20 to 40 ml of local anesthetic solution can be injected posterior to the artery after negative aspiration. So there will be no blood in that syringe. And alternatively, a half amount of solution which can be injected posteriorly and half amount of solution which can be injected anterior to the artery after a negative aspiration. The field block of the brachial plexus with a fan-like manner can be given with a 10 to 15 ml of local anesthetic agent on each side of the artery in a variation of the sheath technique. So complications for that axillary approach is nerve injury and a systemic toxicity of the local anesthetic agent, because sometimes after negative aspiration, there might be a chances of that local anesthetic solution may get absorbed by the artery if the volume of the drug is more than mostly 30 ml in that area. Or intravascular injections and hematoma and infection are the rare complication, and incomplete block because the musculocutaneous nerve, as I already told, which get spared. So in that scenario, I used to give Tiva with the help of Dexcade or Ketofol to decrease the discomfort to the patient while especially surgeon handles at that point or the area which is supplied by musculocutaneous nerve. So local anesthetic agents which I prefer to give the supraclavicular and interscalene block. So it's mostly depend upon the block for the how much the time is required for the surgery and surgical anesthesia and analgesia. So accordingly, I used to give especially the volume and the concentration which I use for supraclavicular and interscalene block. I use bupivacaine 0.25 to 0.5% and ropivacaine 0.2 to 0.75%, which I use commonly. And volume of the bupivacaine, if it is 0.5%, I use to 20 to 30 ml, and if it is 0.25%, I use almost 30 to 40 ml for nerve stimulator. Or mostly I use blind blocks, so I used to give 30 to 40 ml and check for the paresthesia before that with the guided block. And sometimes if surgeon said he might need more time, so in that cases I used to add clonidine 1 microgram per kg as an adjuvant. In some cases I used to add dexmedetomidine also. That is the dose of the dexmedetomidine is 5 microgram. So these are the drug volume and concentrations I used to give. In axillary block, I used to give 0.5% bupivacaine in 15 to 20 ml plus 1% lignocaine 10 to 15 ml, and additive I used to give is 5 microgram of dexmedetomidine. So wrist block. So here are the cutaneous nerve supply of the hand, which is provided by ulnar nerve, radial nerve, and musculocutaneous nerve. So wrist block, for that indications are the surgery of the hand and finger. And hand, it is already told, which is supplied by nerve, that is radial nerve, medial nerve, and ulnar nerve. So the ulnar nerve providing the sensory innervation to the skin of the little finger, and the ulnar aspect of the half of the finger, ring finger, and the corresponding area of the palm. The same area is covered on the corresponding dorsal side of the hand. Here we can see in that schematic diagram by light blue color, the area supplied by ulnar nerve, and orange color which is supplied by the median nerve, and the purple color which is area supplied by a radial nerve. So coming to the functional anatomy of the median nerve. sensory supply, which is providing a medial nerve is palmar aspect of the thumb, index, middle, and radial border of the ring finger, dorsal surface of the distal phalanx of the index and middle and radial border of the ring finger. Now we'll come to the functional anatomy of the radial nerve. Radial nerve lies on the anterior aspect of the radial side of the forearm, as it supplies the sensation of the dorsal of the thumb, dorsal of the hand, that includes thumb, index, middle, and one half of the ring finger as far as distal to the interphalangeal joint. So maneuvers for the radial nerve, for identification of the radial nerve. So first of all, ask the we will palpate in that case radial styloid, and the superficial radial nerve is blocked by injecting a local anesthetic solution just proximal to the styloid process. Here the styloid process is marked by a circle by a sketch pen, and just below it the index finger is shown. At that point we will give a local anesthetic agent. Now the superficial branches of the radial nerve we have to block in subcutaneous injection of by giving subcutaneous injection of LA in a circular manner. So the injection is made proximal to the radial styloid head, which is marked as a circle. The radial nerve block is essentially as a field block, and it requires for more extensive infiltration because of its less predictable anatomical location and division. Its division into the multiple smaller cutaneous branches. So we will give 5 ml of local anesthetic agent, that is 2% dignogen, subcutaneously, just proximal to the radial styloid, aiming medially. Then infiltration is extended laterally using additional 5 ml of LA. So maneuver to identify the median nerve. So here there is a right arrow and white arrow and red arrow in the diagram, which is showing that palmaris longus, it is white arrow, and flexor carpi radialis tendon, which is shown by a red arrow. So we have to ask the patient to flex his hand and oppose the hand, and oppose by another hand. We will oppose the patient's hand so that the palmaris longus tendon and flexor carpi radialis tendon will get prominent, and we will mark it. The second diagram, in which we have drawn two lines and made prominent that both palmaris longus and flexor carpi radialis tendon. So here there is another maneuver to facilitate the landmark identification of the median nerve. We can also ask the patient to accentuate the patient to oppose the thumb with a little finger, so by flexing his wrist, so that we can also make prominent that palmaris longus tendon. So after marking that two tendons, palmaris longus and another one, so the median nerve is blocked by inserting the needle, by injecting a needle in between these two tendons of the palmaris longus and flexor carpi radialis. The needle is inserted until it pierces the deep fascia, and 3 to 5 ml of local anesthetic is injected. Before that, we will get a pop-up after inserting a needle. We will get a pop-up after piercing the deep fascia. Although the piercing a deep fascia has been described the result in a facial click, it is more reliable to simplify the insert the needle unit. It get in contact with the bone. The needle is lit. In that case, we will withdraw a needle by 2 to 3 mm, and local anesthetic agent is injected. We can also inject in a fan shape technique at the same point to increase the success rate of the median nerve block. After initial injection, the needle is withdrawn back to the skin level and redirected in the 30-degree laterally and advance again to contact the bone, and again the local anesthetic agent can be given. After pulling back the needle to 1 to 2 mm from the bone, an additional 2 ml of the local anesthetic agent is injected. A similar procedure is repeated with median nerve, medially, redirection of the needle, and ask the patient for paresthesia in median nerve distribution warrants a 1 to 2 mm withdrawal of the needle, followed by a slow measured injection in the local anesthetic. That means if a needle is get contacted with the median nerve, so patient definitely having a severe pain. So in that case, we have to withdraw a needle little bit 1 to 2 mm, and then again ask the paresthesia or severe pain is get relieved or somewhat get decreased, And if it is happened, then we will continue the LA injecting, or otherwise we will withdraw the needle. There is another landmark guided maneuver we will facilitate to identify the ulnar nerve. So to block the ulnar nerve, here is the maneuver we have did, that outlining the flexor carpi ulnaris tendon. In that case, we will ask the patient to extend his hand, and in that case, the flexor carpi ulnaris tendon will little bit prominent. So in that case, the needle is inserted just medial to the underneath the flexor carpi ulnaris tendon to inject local anesthetic agent is immediate proximity to the ulnar artery, which we are already mentioned here by drawing a dark thick line, which is the ulnar artery. By palpating ulnar artery just lateral to it, we will introduce a needle and ask the patient for paresthesia or tingling sensation. And after that, we will advance little bit more, a needle 0.5 to 1 centimeter, and we will, after giving negative aspiration of the blood, we will give a 3 to 5 ml of LA. A subcutaneous injection of 2 to 3 ml of LA just above the tendon of flexor carpi ulnaris is advisable for blocking the cutaneous branches of ulnar nerve, which often extend the hypothenar area also. So it will helpful to block the more area, and some subcutaneous branches, if the ulnar nerve given in that area, that will also get blocked. So these are my references from which I have taken that material. Thank you for the opportunity, sir.
Thanks, Anu, for wonderful detailed presentation. We will move out to the Samruddhi's presentation first, and then we will take the questions. There are a lot of questions which are waiting for the experts. So we request our experts to bear with us. Is Samruddhi there?
Due to shortage of time, Ashish, due to shortage of time, we'll move on to the last speaker, Dr. Samriddhi Lavhane. Yeah.
She's there.
Yes, sir.
And we'll take the question hour next, after the finishing of Lavhane's madam's topic. Samriddhi Lavhane has completed her MBBS from MGMS Sevagram, MD from GMC Aurangabad. Presently, she is working as assistant professor at Punjabra Medical College. She has worked as a senior resident in IGMC Nagpur and has one national publication and 2 poster presentations to her credit. Her area of interest is landmark guarded, PNS, USG blocks, and difficult airway management. I request Samriddhi to start.
Yes, sir. Good evening to all of you present here. So to complete our platter of regional anesthesia, I'm here to discuss ankle block in a case of uncontrolled diabetic patient for toe amputation. We see a case here briefly. A 62-year-old male patient presented with blackening of the great toe, second and the third toes of the foot, right foot, since 15 days, posted for amputation. Patient is a known case of type 2 diabetes mellitus since 20 years on irregular oral hypoglycemic medications. Patient was also on antiplatelets, tablet clopidogrel 75 and tablet aspirin 150 mg, which was stopped since 2 to 3 days. He is a known case of COPD and medical renal disease. Patient presented vitally with a pulse rate of 112 per minute, blood pressure 160 by 98 millimeters of mercury, and bilateral V's was present. The TLC counts were raised and blood sugars were high. So the plan of anesthesia which we followed was the regional anesthesia, that is ankle block, the peripheral nerve block. The other modalities were central neuraxial blockade or general anesthesia as a last resort. Let's discuss in details about the ankle block. Ankle block is an infiltrative block which is indicated for anesthesia and postoperative analgesia of foot. The contraindications include patient refusal and infection at the site of the injection. It is avoided if a proximal high pressure tourniquet is to be applied for the surgery, as there is no relief from tourniquet pain in such cases. Now, why have we chosen ankle block in such a high risk patient? It is because it provides reliable anesthesia to the foot, requires fewer resources, and is comparatively safer. It avoids side effects like nausea, vomiting, hemodynamic instability, and other complications which are followed by general anesthesia or central neuraxial blockade. Patients with unstable cardiovascular diseases can undergo surgery without significant hemodynamic alterations.
And it is also used for carrying out surgeries in patients with abnormalities in hemostasis or having infections. Also, there is early recovery after surgery in such cases, which leads to early ambulation. Now, the nerve supply of the foot, it is majorly supplied by sciatic nerve, which gives two branches, common peroneal nerve and tibial nerve. Common peroneal nerve gives superficial peroneal and the deep peroneal nerve. The tibial nerve gives posterior tibial nerve and the sural nerve. A component is served by the femoral nerve through saphenous nerve too. Here we can see the cutaneous supply of the foot. Medially, on the dorsal aspect of the foot, we have saphenous nerve providing the skin of medial malleolus and the medial arch of the foot. Here there is superficial peroneal nerve supplying most of the dorsum of the foot. The first web space is supplied by the deep peroneal nerve, and the tips are supplied by the medial plantar and the lateral plantar, which are branches of tibial nerve. The lateral aspect is supplied by sural nerve. For the plantar side, most of the area is covered by the medial and lateral plantar nerves and the branches of tibial nerve, and medially by saphenous and laterally by sural again. Now, for the bones of the foot, we have the dorsal surface mainly supplied by deep peroneal nerve, and the plantar surface which is supplied by the tibial nerve. The important landmarks to be identified in this block are the medial and the lateral malleoli, and the intermalleolar line, the tendon of Achilles, and there is the dorsalis pedis artery pulsations. Requirements for the block, although it is a safe block, still we need to keep appropriate resuscitation equipments and medicines ready. Surgical preparation has to be done, marker, sterile gloves, sterile towels, 10 cc syringes with local anesthetic, 25 gauge 1.5 inch needle, and intralipid 20% if possible, but it is an essential thing which we should have given while we giving the blocks. Total local anesthetic is around 25 ml, 5 to 6 ml per nerve. We generally give 0.25% to 0.5% of bupivacaine. We can also add a lignocaine to it, 2%. Epinephrine containing solution should be avoided due to potential risk of compromising the distal vascular supply of the foot. Local anesthetic is chosen based on the desired duration of the block, with or without additives, and it is always we should always aspirate before injecting the local anesthetic. In some places, there is a cart ready. A nerve block cart is ready, which includes all the emergency medicines and the spinal needles, the regional anesthesia cart, and nerve block trays as well. Patient positioning. The patient lies supine position in neutral position, or slightly internal or external rotation can be done according to the nerves to be blocked. Techniques. We will be discussing the techniques each nerve by nerve. There are two deep nerves, as we can see in this diagram. There is deep peroneal nerve, and posteriorly there is the posterior tibial nerve. Here, these two are the deeper nerves, and they have to be anesthetized by injecting a local anesthetic under the fascia. Whereas there are three superficial nerves. The superficial peroneal nerve, we can see it here. The great saphenous nerve, great saphenous vein, which is accompanied by the saphenous nerve, and the sural nerve is accompanied by the small saphenous vein. They are anesthetized by simply injecting the subcutaneous, by simply giving a subcutaneous injection of local anesthetic over there. The deep peroneal nerve, the nerve lies just lateral to the dorsalis pedis artery and deep to the extensor digitorum longus tendon. It supplies sensorily to the first web space, and the skin is entered immediately lateral to the artery with a 25 gauge needle. The nerve is typically 1 to 1.5 centimeters deep to the skin, and after negative aspiration, 3 to 5 ml of local anesthetic is to be injected. Then we move off to the posterior tibial nerve. It lies behind the tibial artery, which is palpable between the the medial border posterior border of the medial malleolus and the medial border of the tendo-achilles. It supplies the sole of the foot, and the needle is inserted inferiorly 60 degrees to skin, immediately posterior to the artery. It is also penetrating 1 to 1.5 centimeters, and after negative aspirate, 3 to 5 ml of the drug should be given. The needle is pulled back and towards the skin and redirected towards the great toe. After negative aspiration, 3 to 5 ml can be injected, and this fan technique can be utilized to increase the success rate of this block. Then superficial peroneal nerve, the nerve becomes superficial 10 centimeter proximal and anterior to the lateral malleolus in subcutaneous tissue. It supplies the whole of the dorsum of the foot, and 5 to 7 ml of local anesthetic is injected subcutaneously in a circular fashion from anterior to posterior of the lateral malleolus. Saphenous nerve block, it lies close to the saphenous vein over the medial malleolus. It supplies the skin over the medial malleolus and the medial arch of the foot. It is best blocked just above the medial malleolus. We can see here. And the local anesthetic 3 to 5 ml is injected over the medial malleolus circumferentially. The most commonly reported complication of this block is the hematoma of the saphenous vein at the injection site. Then the sural nerve, it lies between the lateral malleolus and the Achilles tendon. So the needle is inserted lateral to the Achilles tendon at the cephalad border of the lateral malleolus. This is the lateral malleolus, and we can inject it over here. And 3 to 5 ml of LA is injected superficially posterior to the lateral malleolus. And it is a field-like distribution with a goal of creating a ring of anesthesia once the superficial and saphenous nerves have been blocked. Now, how do we assess this block? The saphenous nerve, we can see by the medial ankle or the calf sensations. The deep peroneal nerve is assessed by foot flexion and great toe flexion and the sensation of the first web space. Superficial peroneal nerve by foot eversion and sensation of the dorsal surface of foot. The tibial nerve by the great toe extension, the sensation of plantar surface. And the sural nerve has sensory only supply to the lateral border of the foot. Complications, although again it is a safer block, but complications may occur. Neuropathy, which may result from an accidental intraneuronal injection or pinning of the nerve against the bones with the needle at the time of injection can occur. New paresthesias that do not resolve may occur. And there is always a risk of local anesthetic toxicity resulting from direct intravascular injection. Despite it being referred to as a volume block, local anesthetic plasma levels are relatively low following an ankle block. So to summarize, ankle block is a safe and reliable procedure capable of providing adequate anesthesia for many types of foot surgeries. The benefit of reducing intraoperative risks to the patients who are poor candidates for general or neuraxial anesthesia, or while providing optimal pain control with minimal side effects and potentially reducing the perioperative cost by allowing early ambulation, makes this technique an excellent choice for the patients as well as the anesthesiologist. These are my references. Thank you and have a happy Republic Day.
Very good presentation, Samruddhi. You have covered almost everything about the ankle block to be known.
Thank you, sir.
Can I request though we are running short of the time, I request our experts to wait for at least 10 to 15 minutes. There are so many questions with us, even asked by the audiences. Sir, Sam sir, Diwan sir, 10 से 15 मिनट.
Yeah, I'm here.
Yeah, fine. So my first question will be for the Cham sir. Sir, as Anup explained that in axillary block, there is the sparing of the musculocutaneous nerve. And musculocutaneous nerve, as everybody knows, it spreads around the distribution of the musculocutaneous is mainly towards the radial side of the forearm. So how to block this musculocutaneous nerve?
First of all, congratulations to all presenters. It was a very nice presentation by all faculties. it's very difficult to block a muscular nerve by anatomical landmark. But if at all you want to block the muscular cutaneous, just go posterior lateral to the axillary artery and infiltrate the drug about 4 to 5 ml. It will block the muscular cutaneous and also infiltrates around the axilla. It will block the cutaneous nerve as well as muscular cutaneous nerve. It's
And
basically in the belly of the coracobrachialis muscle. So it is very difficult to find out the nerve where in the anatomical landmark way. So basically it is lying in the posterior lateral part of the artery. So you can block that nerve by injecting a little bit around 3 to 5 ml of local anesthetic.
Fine. Thank you, sir. One more question to you only, sir. Sir, share your practical tips to increase the precision and decrease the side effects of the interscalene block.
My anatomical landmark is first cricut cartilage, then lateral head of sternocleidomastoid, a line joining lateral cricut cartilage and lateral head of sternocleidomastoid is just put a two finger over the lateral head of sternocleidomastoid muscle and go laterally. The two finger will get deep into the interscalene groove. That is the point of injection for interscalene block. And don't go too proximal and the direction of needle towards the ipsilateral nipple. That's the point. And you should not go too deep inside whenever you are giving interscalene block. That's only my anatomical landmark interscalene block. So if you are not proximal, the chances of blocking the phrenic nerve is it should not be proximal as well as medial. The injection should not be medial and proximal. Any more expectation, Ashish?
Sorry, fine. Divan, sir?
Yes.
Sir, where do we stand medically in this era of PNS and USG guided while performing landmark guided blocks?
So let me come to what Cham said initially. Palpation of the interscalene groove is the most important thing, because even if you have got all the anatomical landmarks and if you are not palpating the interscalene groove, then it's not possible to give interscalene block, because the brachial trunks, they emerge from the between the scalene muscles. The second thing is you can insert the needle wherever the interscalene groove is palpable. It may be at C6, it may be at C7. Now, what the previous speaker showed about the subclavian perivascular, the point, I thought it's a bit higher. It's almost like interscalene given at a lower level. At the level of C7, one has to be cautious about the vertebral artery at that point of time. Now, Cham said that you need to go towards the ipsilateral nipple. Probably he's speaking about the longitudinal interscalene, where we used to use that for the catheter techniques. What my preference is if you're doing anatomical landmark, you go perpendicular to the brachial plexus, so that the needle doesn't move into the vertebral artery or into the epidural space. So these things to be kept in mind. Now, regarding what you said is about the medical legal or the litigations when you use anatomical landmark. I think if you have done your homework perfect, like you have explained to the patient, counsel the patient about that you are going to buy anatomical landmark, and he's not bothered about what you have, what you do, and he's accepting the technique. You don't have a neurostimulation, that's fine. You can explain to the patient. You don't have ultrasound, that's fine. You explain to the patient. Because anatomical landmark in till today it was given with perfection. We have done it perfection in the past, and we moved on from landmark to neurostimulation to ultrasound, and it's very well written in the books, and it's also written how to avoid the complications. So if you have done everything perfect, and if your notes whatever you have jotted down all the notes perfectly, so I think it still holds good. I don't think so that you should face any problems even if you are doing with anatomical landmark, if everything is in perfect place. You are always supported in literature. A lot of things are written in literature, though they are of 1960s and 1970s, they still hold good. all your neurostimulation is based on anatomical landmarks. Your ultrasound is based on anatomical landmarks. So why one should still fear about using anatomical landmarks? Except one thing, that the needle which you must be using is a 23 gauge Quinky, a sharp needle. Probably that should not be used. Probably you should replace it with an insulated or a blunt needle. Don't try to make it blunt now. So there are insulated needles. You can use those insulated needles, and you can also move from a landmark to neurostimulation like what we did. You can move from neurostimulation to ultrasound. I think you all, most of you are working in corporate hospitals. By the way, very nice presentation of the ankle as well. So I think now you can move from even from the landmark to ultrasound if you are doing if you are working in specialty hospitals. That is my take on this. Whatever you said.
Thank you, sir. Again, Divan sir, in one of your in the Journal of Korean Journal of Anesthesiology, you have presented a comparison between the infraclavicular and coracoid tunnel block. Sir, can these blocks be given on landmark techniques?
Basically, the subcoracoid block was a novel technique which was introduced by me. We have yet to compare it with the traditional infraclavicular, but that was based on the MRI, functional MRI studies. Now, functional MRI is again very advanced studies where you can see all the nerves in the brachial plexus at the level of the trunks, the cords, and the divisions as well. So it was based on that you can do a longitudinal ultrasound guided block, which was called as a subcoracoid block. Probably I'm really unsure, and I would not ask anybody to do that with a landmark technique because there are no landmarks. It is just with the ultrasound. You position the ultrasound in the line of the brachial plexus and introduce the needle in plane. That's all it is. But for that, I really don't have any answers.
Thank you, sir. Cham sir, how to go with the continuous regional blocks in low profile, low budget setups like ours?
My experience about the continuous block is not very much, and I am not used this. I think Divan is using continuous block, so he is the best person to talk about.
Divan sir.
So these continuous blocks now, in the past when I used to use a epidural needle, 2E needle, and a single the catheter, which could be a multi-hole or a single hole catheter. Now, based on anatomical landmarks, I used to do two blocks quite regularly. One was the infraclavicular block, and the second was the lumbar plexus block. I did some contrast studies. Many times I found that the contrast was not in that particular area, in that particular space. So I started using the Contiplex sets. Now these Contiplex sets are available in the market. There are B Brown sets. Then you have the Pajunk sets, which are also the second generation sets. And these are the ones that we commonly use for all the blocks. And nowadays I started using stimulating catheters. So the stimulating catheters are about that you have a stimulating needle, you insert the needle with ultrasound, you did not stimulate because we know we are close to the brachial plexus, for example, and then you insert this catheter. Now this catheter can be stimulated. So once you stimulate a catheter, that will evoke the motor response. For example, if it's in the interscalene, it will evoke the deltoid or the biceps. Today only I inserted two of these stimulating catheters. Now, interestingly, in the post-operative period, I do not inject any local anesthetic. I just re-stimulate these catheters. So every 8 hours, I just stimulate these catheters, and this is what is now the recent trend in most of the research areas, where you just stimulate the catheters and don't use any local anesthetics. At 24th hour, we remove that, and we're trying to assess, along with multimodal analgesia, how you are able to decrease the opioid consumption. That's what we are looking at. So this is how the trend is now moving away. But for you who have been doing the blocks and with anatomical landmarks, so in that case, I think epidural needle or maybe a stimulating epidural needle to identify at least the first thing, to identify that you are close to the plexus. And then once you do that, then you insert the epidural catheter. preferably a multi-hole, because a single hole catheter, if it gets obstructed with a clot, then you don't have anything left. You need to remove that. And then you insert the catheter not more than 3 to 4 centimeters beyond the tip of the needle. That should be the position of catheter. And then you can inject intermittently. We used to do that in the past. 0.2%, 0.25% bupivacaine we used to inject every 8 hourly. And then we started having infusion pumps. We started using infusion pumps. So that is how you can do this.
It is a routine 18 gauge epidural sets, or
Yeah, it's a routine
finer than
18
that?
gauge epidural sets. Yes, yes.
So how to avoid the nerve damage or internal injections while with these paresthesia techniques or landmark guided techniques?
Yeah, that's a difficult question actually, because when you obtain a paresthesia, that means the needle is in very close contact to the nerve. Now, how close contact to the nerve is, you cannot judge it unless you have got ultrasound. Now, when we do a lot of these blocks, when we started using ultrasound and neurostimulation both, we found that at 0.8, 0.6, and even 0.4, the needle tip was a bit was far away for 0.8, then 0.6, then 0.4. At 0.4, 0.3 milliamperes, the needle tip was very close, but we still did not obtain paresthesia. Now, all the time, you may not obtain paresthesia at all, because the motor and sensory nerves, they intermingle with each other. So sometimes at the superficial part of the nerve, the sensory fiber would be there, and needle in contact will produce paresthesia. But some at times at the same level, the motor fiber, if it is superficial, the needle in contact will never produce paresthesia, and then you will try to go more deep and end up inside the nerve. So you have to be very cautious when you are trying to obtain a paresthesia. If you're obtaining paresthesia multiple times, that means you are likely to get multiple times nerve injuries. So this is the reason why paresthesia has become obsolete nowadays. We are going in for more of neurostimulation, but finally, as literature says, ultrasound has become the gold standard.
Samsa, your word on this?
Yes, same thing. I think everyone should start using nerve stimulation. At least, if you don't have ultrasound, at least buy a nerve stimulator. It is not very around, I think, 40 or 50,000, and we should spend such amount for a good type of anesthesia. And I request everybody who are using paresthesia technique to buy nerve stimulator and start using nerve stimulator for brachial plexus. As the answer said, for preventing one, just if there is a pain while injecting, uh, you have to just withdraw the needle, because that will give some type of idea that you are inside the sheath, or you are stimulating the nerve directly. So that will prevent injury if you are using paresthesia. Similarly, while injecting, if there is too much pressure, then also that gives some idea that you are inside the sheath. You have to withdraw the needle. And similarly, to avoid intravascular, you have to repeatedly aspirate. With every 2 Ellicott, you have to aspirate, because with every aspiration you may go inside the artery or vein. So it is not 100% sure with first aspiration that you are not inside the artery or vein. So for preventing intravascular, you should aspirate with every 2 ml injection. That's my take for prevention of intravascular, and also for the any injury to the nerve.
So to summarize this thing, so to avoid nerve injuries and improve the paresthesia techniques, one thing, the needle should be blunt. Second thing, avoid multiple times the paresthesia multiple times. Third thing, avoid excessive pressures. Fourth time, if there is pain, withdraw needle and aspirate. Right? And try our best to move to the PNS and ultrasonographic techniques. Thank you. We are very much thankful to Dr. Cham and Dr. Sandeep Diwan sir for your expert comments and solving our questions. Handing over to Rohit Ganeriwal, sir.
Thank you, Ashish. Good evening, everybody. Now, last but not the least, to say a vote of thanks as Secretary Amravati I'll start off with the vote of thanks directly. To start off with, I would like to thank Dr. Shilpa Tivaskar Madam, West Zone GC member, who brought us to today on this one dais. Without her efforts, today's program would have not been possible. Now I would like to thank Dr. Sandeep Diwan sir, Dr. Chandrasekhar Cham sir, who managed to take out time from their busy schedule and join today's webinar. Be as an expert to guide us through the various lectures and share their knowledge from their immense experience. I would like especially give thanks to Dr. Indrayani Madam to join us for today's webinar. I would like to thank today's speakers who have taken their immense effort to share their knowledge and experience on various topics. Thank you, Radha Madam. Thank you, Anup. Thank you, Rohit Hadgaonkar. Thank you, Minal. Thank you, Samriddhi. I would like to thank all the office bearers of the Society of Anesthesiologists, Maharashtra State, Dr. Balaji sir, Dr. Avinash sir, Dr. Rajesh sir, Dr. Anita Madam, Dr. Vikas sir. They all helped the Amravati branch to come together at state level for organizing this webinar. Thank you all. Last not the least, my president, Dr. Radha Savdekar Madam, who tirelessly worked day and night coordinating between the senior members of the state and center and other colleagues of the local branches to make this event a memory and landmark in the history of Amravati society. I feel myself honored to get an opportunity to work with her. I thank her and also promise her my full support for the future events to come. I'd like to thank all the office bearers of the Amravati Society and also all the members who cooperated and came together in one call to make the event a success. Thank you, Amravati. I would also like to thank Jeneka Technologies to give us this technological platform allowing us to come together. Thank you, Jeneka. Thank you, everybody. It was a very great presentation by all the 5 present colleagues. Thanks for being here with us. Thank you.
Thank you very much.
Madam, anything?
Thank you, sir. It was a great pleasure. Thank you for accepting. Thank you, Cham sir. Really a great pleasure to have you both. And thank you for accepting the invitation. We are really blessed to have you till 10 o'clock. We are sorry to.
Yes, really. Sorry, we have
Yes.
taken a lot of time.
It was really a great opportunity to have experts like Diwan sir and Cham sir with us through the entire session, who patiently listened to our presentations, also cleared whatever doubts we had, and we really feel lucky that we had been given the opportunity to present at along with the SAMS member. Thank you very much.
And as
Thank you
Rohit,
very much, ma'am. It was very refreshing knowledge of anatomical landmarks. It took me to the past, and also the techniques of spinal. It was something very novel. Thank you very much.
Thank you. Thank you, all my senior members also of my
Thank you,
Amravati branch.
thank you very much. Congratulations.
Thank you all.
Dr. Rohit said
Thank you.
it was continuous, non-tiring effort by Radha madam, many rehearsals, many practices, many dry runs. Yes, madam, it was very nice. The presentations were
Actually, this is for the first time, I guess, that Amravati Society has presented on a technical platform, a webinar on its own. That's why we were a bit skeptical regarding the internet connectivity, some issues we may not be able to handle. That's what we had mock drills also about it. But everything worked out fine. So that is a simple saying, you take efforts, you reap the fruits. Thank you.
Thank you, everybody.
Thanks a lot and
Thank you very much,
congratulations,
Shilpa
everybody.
madam.
Thank you, Jam
Yes.
sir. Thank you, Diwan sir.
Thank
you, Tivaskar madam.
At the outset, it was all because even Tivaskar madam was behind this motivation. Thank you very much, madam.
Yeah. So I'm the host. I'm ending the meeting.
Yes.
Yes.